Good morning, good afternoon, and good evening, digital health scientists, investors, entrepreneurs, executives from around the world. Thank you for joining us at our humble virtual abode called the Healthcare Innovation Technology Laboratory, where we explore the latest in digital health adoption and evidence each month to go through and understand what's happening and how it's happening in the world. So my name is Stan Kishnowski. I chair the Healthcare Innovation Technology Lab. I'm going to be partnered today with my co-executive, John Hammett, who is the global director for HITLAB and is a 40-year veteran of digital health, coming from the likes of being the CIO at Johnson & Johnson for 10 years. And we'll be going through the most impressive schedule you'll see in digital health these days of experts and people who care deeply about improving healthcare delivery, patient care, and life sciences through digital technologies. And we're going to be talking about a whole slew of things today, but we're really focusing on transforming healthcare through digital. And the formal title is Transforming Health Through Digital Tools from Concepts to Applications. And again, we focus predominantly on the evidence. So what studies are out there that are showing real adoption of technology? Not always what we always thought it would be. A lot of people thought digital technologies in 2025 would look a certain way during the pandemic. And what we've learned over the last 3 years is that the adoption of digital is highly asymmetrical, not at all like what we thought it was going to be 5 years ago, but now much different than what we thought 5 years ago. As you all know, most of you at least, it's a 3-hour program, and we're looking forward to launching hour number 1. And that is going to include a host of very important notifications and alerts and new evidence that we found over the last month. Our scientists and researchers, designers, epidemiologists, biostatisticians around the world, over 100 now, do this research for you so that each month we can share what we're seeing. And don't forget, the chat box is open on this webinar. So this isn't something where we close it and you're not able to interact. As a matter of fact, this is a very dynamic program. We want to hear your questions. Please link in with myself. Sammy has placed my LinkedIn into the chat and ask me questions through that. Connect with me if you have any questions or follow-ups or any ideas for future programming. We love to hear from you. You guys are why we do this, our audience, and certainly our community. We're going to start off today with our board chairman for the Breakthrough Alliance Europe board, Laurent van Leberg, and he's also the CEO and founder of Ballas Invest, a supernova of venture capital firm. And then he's going to be interviewing a couple of folks. I'm going to be interviewing him about the Breakthrough Alliance conference coming up next week in Paris. And then we're going to hear from him as he interviews a Breakthrough Alliance winner from 2023, a very impressive company that's creating a goggle, a lens, if you will, a pair of glasses that can help people who can't see again. Truly revolutionary, and it is working. We actually are seeing people use it who have been blind and now can see again. At 11:30, we're going to hear from Hilla Shaviv, the founder and CEO of Gals Bio, a recent winner from the Women's Health Tech Challenge that we did recently. And then we're going to wind up hour number 1 with our own Ansley Bowen, talking to Lada Shetty from the firm, the LP advisory firm, Founding Investor. So Lada will be talking to Ansley about empowering change and how venture can be used to change society, especially for first-time investors. And so with that, Laurent, very good to see you online today and looking forward to seeing you next week in Paris. How are you doing?
Doing very good, Stan. Very happy to be here.
Fantastic. And if you could, for the audience that doesn't know who you are, just do a brief bio about yourself and Ballas.
Yeah, so look, I come out of 25 years in big pharma over the world, and actually decided to move to becoming an investor. This was at the end of mid, actually 22. And since then, I invest as a business angel all across Europe, really focusing on all segments of digital health. I did a few investments with business angel actually in the United States. And then I'm raising a fund, Keles, which is a European digital health growth stage fund. So really focusing on growth stage investment, Europe being really at a stage where companies can really scale become big, and we hope to create some unicorn or alphacorn, as we call it, when you are at half of the size.
It's impressive. And I think the audience would love to know, as we're talking about digital health adoption around the world, and a lot of what people learn are going to be through conferences that they attend, virtually with HITLAB, or even in person as well. What unique opportunities are you seeing with this new conference that's being launched next week with HITLAB and with Ballas and Hotel Dieu and the Breakthrough Alliance Europe conference? What's unique about that relative to startups who are looking to scale up their digital health companies across Europe?
Yeah, this is really obviously you're all going to different meetings which have specific focus. And this one with you, Stan, and the team, we said, how do we offer something really specific for startups, for investors, and also for accelerators? And we focus this meeting on this theme of scale up across Europe, because believe it or not, it might look easy for you to go from one country to the other. It's not so easy. So how do you scale up across Europe? And then two is the bridging with US, which is really two ways. US is obviously a very important market for everyone, but there are actually increasingly opportunities for US startups actually to come to Europe. And actually with HITLAB and Stan and actually Hotel Dieu, we are actually building this network of selected accelerators that can really help startup to do what they need to do.
That's brilliant. And again, I think for folks who are not familiar with the Breakthrough Alliance Europe and certainly the BTA Summit, the BTA Europe Summit, what would you say, how can startups best prepare to connect with investors and accelerators in Europe, and really during the event itself to maximize their networking opportunities while they're in Paris?
Yeah, so look, I'll say something quickly for those who will connect remotely, because I understand not everybody can be there. But here we identify the names of companies who have same type of issue, or maybe identify accelerators that can help you as you want to get to Europe, or as you want to scale up actually across Europe. What I see more and more, many have been in a culture of I have my own problem, I have my own startup, I have my own path, and let me work on it. But actually, since maybe time has got a little bit tougher with funding, there is a lot of connection that can happen between startups. You are facing very similar problems, and you can actually a lot more partner to address these problems. Of course, some go until merging, but you don't need to go there before you see you are completely comfortable with that. But partnering, for example, you work on patient care, you need to create some apps, technology costs a lot, you can do stuff together. You need to create a partnership or link relationship with hospital. I mean, all the startups have connections with their own regions, so you can put this in common. And when you deal with big customers, if you are strong in France or strong in Belgium or strong in Germany, it's irrelevant. But if you are together, suddenly you become a European player. So these identify also startups that you can work with, exchange with, and a lot more than a nice discussion in a meeting, but really do business with, because I think this is definitely a path that the winners will take.
That's brilliant. And what are some of the highlights that your conference next Tuesday and Wednesday in Paris at Hotel Dieu, the oldest European hospital created there? What is it you're seeing are the highlights?
Look, I shouldn't say it, but Notre Dame is in front of Hotel Dieu, so I'm pretty sure people coming there will want to sneak by and try to see it, because it's absolutely beautiful. And of course, I have to say it. But if you get into Hotel Dieu and the hospital, look, the few highlights. First one is we ask McKinsey actually to give us the lay of the land with really facts of what is happening, what are the companies, the startup really succeeding, and what are usually the challenges, because it's always good to know what's really happening before we get everybody's opinion. And actually, McKinsey will stay with us for the 2 days and help us conclude on so what, and what is the call of for action or help for the people. So that's one. Two is we're going to do a speed dating in this meeting, actually each day, midday. And the speed dating is really for you, the participants. You'll get people based in the US, you'll get people based in Europe, and a mix of investors, and accelerators. So pick the ones that you think you are most interested in. And of course, 10 minutes, you won't solve everything, but if you get the right contact, the right follow-up, this will be really great. And maybe three, what we're going to do is we have split the 2 days by theme. We have tech bio, we have digitized trial, we have AI imaging, and we have patient care. And we really mix these so that the discussion I was talking about start taking place. So that's these are three highlights, and I hope you're going to create others. I look forward to some good surprise.
That's great. And there are going to be a lot of different people there, from government executives to physicians to people from life sciences, and certainly startup community, the investor community. What kind of trends are people going to be talking about? And what would you say for people that want to go, what would you say they should be prepared to discuss?
Look, obviously, talk about your company. That's always good to hear about it. But keep in mind this theme of a scale up across Europe and then bridge with the US, one way or the other. So I think that's really what people want to hear about, and what they can do, what they can do with you, or what they can learn from you. So that's one. I think two, you'll see we have set up different panels. We have one with a few accelerators, including HITLAB, and what each are doing together to create this small community of people who will really help startups to do that. We have another panel that I think is very interesting, is patient care, startups that are actually not direct competitors, but talk about the common challenges and what they can do. So you'll see these a lot of sharing. So be prepared to create your own panel in the coffee break, in the cocktail. And then three, come with the maybe the unusual. I think time is more challenging, as I was saying, with fundraising being a bit tougher. I'm sure in US, but I can tell you in Europe there are some rebalancing of funding from health, maybe a little bit to defense and some other areas. So we need to be a lot more creative in what we want to do. And then last but not least, people need to see a solution that really work. I mean, I still hear too much that digital health is for the future, or it's coming and so on. It's actually already there, and we need to make this a lot more visible so they can accelerate.
And one of the elements of this program, which is very different, is that HITLAB actually curates meetings between attendees, so that when you attend, you can actually find out ahead of time who's going to be there and who you can meet with. And then another element, which is highly dynamic, and you see in some other conferences as well, is this executive kind of express meeting. It's also known as like speed dating colloquially. And so for startups who are planning on attending and want to meet with investors, what would you tell them to prepare for these meetings, and how should they present themselves?
Yes, you obviously always have to be prepared to do these 2 minutes, 5 minutes, or 15 minutes actually pitch. You're gonna have a lot of 2 minutes, 5 minutes because people want to see a lot of others. So be prepared to get to the point, obviously, of what you do, but maybe what you need. And I can tell you a lot of investors or accelerators, as I said, won't have time to solve the problem, but if you leave with the right contact, it's gonna be great. I think two, you'll see also going around. We have actually a podcast interviewer that's going to ask you some question about the meeting, about what you need, and you have a chance to do your 30 seconds, 2-minute pitch. This will be a podcast, short reel that will be posted on YouTube. So use it as something that will get your message across, and we'll do it in a way that you can actually reuse. I think what is very important is really come prepared. Come prepared with your small pitch, as I was saying. That's an exercise, the 2 minutes, 5 minutes. I think two, come prepared with this element of scale up and bridging. And I think three, think about what you can bring to the others, because this is going to be something we're going to insist a lot on. And the startups I know, I really push them, and I can direct them to those that can maybe give them some insights, but come with your own insights that you think could be useful for the others.
It's fantastic. Last question, is we're almost out of time here. And again, I know you and I could talk for hours and hours and hours about this, and we will next week over some great wine in Paris. But in your experience, and now you've got so much experience, Laurent, in this area, How does cross-continental and cross-national collaborations, particularly between France and the US, but Europe and US, play a role in accelerating digital health innovations, and how is this sort of meeting crucial to those sorts of connections?
Look, it's a lot easier for you, Stan, for me to stay in our country and everything is around and you don't have the travel and so on. But I think this was good for venture and it's the early venture and just getting started with digital health. I think now as I'm talking about creating this alphacorn or unicorn and really impacting healthcare across Europe and same thing in US, getting this innovation also coming from Europe or going to Europe. I think it's very important actually to get to this next level, of connecting this ecosystem, connecting these accelerators. And I have to say, I mean, this takes a specific community of people who want to do that, And look, Stan and I, we have long discussions and actually we enjoy really pushing these with Nicolas Castaldi from HITLAB. I mean, we got to hear that is really helping and pushing for that, not just focusing on what to do in Paris, because he thinks that Hotelier has a role to play all across the continent, if not worldwide. And I think the selected group of people that we got into this conference, the mix that Stan was talking about, are really people with this mindset, and that's the community that we are creating here. And of course, calling on those from you, who think that you can bring to this community with the same DNA or genes, because of course after this meeting there is a bit of a launch here for this Europe chapter or Europe page of HITLAB. There will be a lot more activities and contribution we will ask all of you to give.
That's fantastic. Well, Laurent, thank you very much today for joining and giving our audience a better picture of what HITLAB looks like and what the BTA Summit looks like in Europe. And remember, for our audience, if you're not able to make it this year, this is now an annual event at Hotel Dieu on the first day or so of April, last day of March. Next year, it'll be March 31, April 1, 2 days again, Tuesday, Wednesday. So please do make arrangements to join us and either contact myself or Laurent about joining us next year. Again, Laurent, thank you for joining today. And I'm actually handing the microphone over to you, the virtual microphone, if you will. And we're going to hear from Neil Weinstock, the CEO and founder of Solid with 3 Ds, a revolutionary eye device that's going to change the way blindness is actually is dealt with these days. But all right, Laurent, over to you.
Yeah, thank you, Stan. Yes, that's great. And I was looking to see if Neil, you're on, and here you are. And it's great to have you, in a way, to have you back into the sessions. After the winning of the award of HITLAB, it's always great to see how things progress. But then I'll ask you a few questions, obviously, and I have to start maybe with a basic one for people. But can you tell us, for some, and remind us for the others, what Solid is doing and what Solid is about?
Well, we were blessed greatly to be able to discover some brain activity that no one ever realized before. And if anybody wants to hear about it in detail, we have a white paper now that is very explicit. And we've realized that if we present multiple separate in-focus images to all different areas of the retina, the brain can automatically put together stereopsis from that. And in fact, with our beta device that we showed at the Consumer Electronics Show just this January, which was a spectacular success for us, we had 128 separate images, like the brain getting 128 separate eyes and automatically constructing a full field, very well focused, very high acuity image from all these multiple separate, each fairly low acuity image. And there's a lot of things that we can do with that. There are so many applications, but the low-hanging fruit, which you've already proven in preclinical trials last year, is if there's some area of the visual field that's missing, particularly what we tested for was macular degeneration and Stargardt's disease, which present very much the same thing. The visual field gets filled in, and people can see in the full field, even though most of the field may have been blocked previously, because very typically for macular degeneration, it's the central area of the field that's missing. The central area goes to the fovea, which normally gets over 90% of your visual acuity, and yet we allow people to see even if that's totally blocked. And we think it's going to work for many other applications too. So what's Solid doing now? We're building our product, and we expect to have lightweight, simple to use electronic glasses. I think by the end of the year in quantity. We will see, you know, when you're manufacturing something, things can happen. We rely on contractors, but we seem to have things nicely progressing. And we've gotten so much tremendous support from investors, from people who have written into info@solid.com and all kinds of other ways of contacting us. We have more people on our waiting list than we're going to be able to serve with the first generation of these glasses, and that's fantastic. So we're making the product, and we're also simultaneously making, call it a second product, but in very low quantity test devices that we can use in university hospitals, physicians' offices, and have run people through a number of tests that'll help us code our product as well as understand what we can do for a number of other eye conditions.
That's super actually interesting, and of course the question that comes right after that is that what brought you to focus on this field of macular degeneration and this field versus another?
Well, you know, I'm an engineer. I know nothing about other than being a fellow who wears glasses, you know, and I know a little bit about as a user, right? Nobody ever sets out to discover something new and actually discovers the thing they set out to discover, right? That would be, I don't know if that ever has happened. We set out to do something that may seem entirely different to you, which is my founding partners and I knew that we could develop a far, far better solution for what's known as auto stereo 3D, or 3D without glasses. And my partner in founding the company in particular, his name is Rich Muller. He was a professor at Berkeley. He's now emeritus, brilliant physicist, developed the math so that we could define exactly how much depth and how much crosstalk in what's known as light field imagery or integral imaging arrays. And that allowed us to come up with a prototype that had more depth in 3D space without glasses than anyone had ever thought possible before. I looked at that back a few years ago, and now my father had gone blind from glaucoma before he passed away. And I started to think maybe there's something that we could do with near eye systems. I had an inkling that we could get to where we are now. And took a few years of testing and development and making lenses, and we got there.
That's quite interesting, actually. An engineer. I mean, obviously, there is a lot to say about how you get started to do a discovery and where do you end up. You know, that's also probably called some good opportunism, as you see technology working one way or the other. But maybe I want to go back to what you said at the beginning. Giving some maybe an initial window on the technology and what you can do. Can you tell us a little bit more, you know, with these 128 image, how you actually can restore the vision or restore part of the vision for people who would have been blind without this solution?
Yeah, now if you're completely blind, if there's no information getting through the optic nerve, we can't help you. Wonderfully, we had Stevie Wonder visited us at CES. We can't help him. Now, there's other technologies, other science that people are working on that perhaps can help people with really, really severe total blindness. And I wish them well, and I've been aware of some people working on that. But what we're able to work with is if there are some active areas of the retina, and some people who feel like they're almost totally blind now have now tried our test devices, And while they may have just a tiny bit of light coming through in this corner or that corner of one eye, and we play around with our test device a little bit, they find, wow, you've expanded my visual field something like 100, 200, 300%. As I said, there's so many applications for the core technology, we're only scratching the surface. But what we're doing for people with macular degeneration is they get that image multiple times over. And in fact, the product we go to market with later this year will probably have on the order of 180 separate images. The more, the better. And the wider visual field we hit, the better. And we're actually addressing a very, very wide angle of view, much bigger than people get from VR and AR glasses now. And doing so with, what the brain perceives as a stack of multiple images that it puts together automatically. As we go forward, we also are expecting to be able to detect the specific presentation of, in the case of macular degeneration, a scotoma or multiple scotomas that someone might have. And then we can turn off the light to those specific areas and only provide our multiple images to those areas that have good perceptual ability. And we think that should give us even far, far greater performance than what we've already proven in the tests that we've conducted.
And as you have been doing the research and the clinical tests, can you share with us what were your good surprise and maybe your bad surprise as you went through these?
Well, what we've been able to test so far is very limited. And I want to be clear, these are not clinical trials. We've called them preclinical trials. We actually don't need clinical trials to go to market because our device fits into what the FDA classifies as low vision aid devices. There are many of these things out on the market already. They don't do very much. They might magnify the total image, might add some brightness, and people don't use them for very long, even though they're quite expensive. What we were able to test with a very simple prototype last year was reading speed. And we had people look at what's called a Bailey-Lovie test, which is a scrambled word test. And we presented it to people the way that they would normally read it at the same overall visual angle that we could present with our device. And then, or vice versa, we flipped, whether we showed one first or the other first, and we showed a different but similar scrambled word test the way that people could see it through our device. And almost entirely, people read significantly faster with our device. What really surprised me was when people had what they considered to be almost total inability to read or total inability to read. There were many, many times in the trials where people could read with our device and couldn't read at all normally. There were surprises on the other side. If people had fairly, or what might have even looked to an ophthalmologist as quite serious macular degeneration, but were able to read very quickly normally. I mean, some people adapt and know exactly this corner of their vision and can read as quickly as I'm speaking now. We make them read faster in that case, right? I mean, how much faster can they go? I can't insist that, a 70-year-old test subject speed read for me. It just doesn't work. There's no way to test it.
And maybe the last question there. I know some people are very eager to hear that, and actually it's a double question. One is, in general, what are the key next steps for Solid, but maybe more specific, when will there be a prototype or a V1 available for people actually to get access to?
Well, we think we'll have our golden samples from the manufacturer. We're hoping in the summertime. If everything works well with those devices, that's the product, and we just make more of them. What often happens, though, is that something or other goes wrong. You get a few samples and you fix what's going on in the samples. Now, also, we'll have these test devices, which will be running on a desktop computer and something that the patient will put their head into and get tested for various things. These should be we can say quite definitely available in the summertime. We have agreements with a few locations in the United States and in Europe so that people can come into our testing sites. And I think there are many, many people who are eager to do that. So we'll start conducting these tests in the summertime. And yeah, at the same time, you know, like any other startup, we're raising more money and we have some deals in place and that looks good. And we're doing everything you have to do to start up a business, including, you know, meeting payroll for more and more engineers. So.
Well, Neil, that's really exciting. And of course, 15 minutes doesn't make justice to that. And I actually advise people listening to us, to you, if they want to learn more, of course, connect with Neil or reach out to Stan, and we'll make the connection. It's exciting, and I'm sure everybody's looking forward to getting some news from you somewhere in the summer when the first prototype will work. So really looking forward to it.
Thank you very much.
Thank you. And on to it, I think we give it back to Ansley or to Stan.
Yes, no, fantastic. Thank you, Laurent. Fantastic interview and just an incredible innovation. That's really what we're all doing this for, is to search out and discover these sorts of innovations, help them get evidenced so that they have the materials they need to go to customers and investors and grant-funded organizations and help them be really promoted amongst patient populations and the professionals that are working with patient populations to get these technologies out there. So just absolutely phenomenal panel and I mean, in a fireside chat, and appreciate you both. Thank you.
Bye-bye.
That's fantastic. So I think we are off and running, and we've got a phenomenal first half hour past us now, and we're on to the next half hour of hour number one with Hila Shavif, and the CEO and co-founder of Gals Bio and Tulipon. Hila, can you hear me?
I can hear you. Can you hear me?
I can. Good to see you as well now. And first of all, how are you? And tell our audience, where are you?
I'm fine, and I'm in Tel Aviv.
Fantastic. That's great. And just amazing what you've done with this company. So if you could just tell us a little bit about Gals Bio and how it's transforming women's health over the last few years, over the next generation of women's health.
Okay, so I'll do, if you don't mind, I'll do an experiment because I heard the previous lecture and he said the pitch is, the 2 minutes are very important, and I want to echo this. And recently I started to have a new pitch, so I will share it with you. So what I like to say today is, you know, the monthly bleeding, because thanks to it, all of us are here. So we don't call it the monthly bleeding anymore. We call it the monthly biopsy. And what we did in Gals Bio, we developed the technology that enables to turn it into a monthly biopsy.
Amazing. And so tell us, how will that transform women's health over the next generation, do you think?
It's a totally new branch in health, in women's health. Basically, we developed the technology that enables to collect the vaginal effluent, not only menses as well as any other secretions. And then we can do liquid biopsy. Currently, the liquid biopsy, in the beginning, the liquid biopsy will be done in the lab. With time, we plan to do it at home. And it depends on the indication. We are now part of a cohort. We are developing in the EU, we are developing a POC device to diagnose endometriosis. So not too far away from now, if today it takes 5 years to diagnose endometriosis, the woman will need only 1 or 2 menstrual cycles to diagnose herself at the doctor's office, thanks to this technology. We are started to work on cancer diagnostics. And this is only the beginning, the tip of the iceberg. We can, the vaginal cavity is a unique, very unique cavity. It's invasive. It contains invasive data, but it's basically non-invasive, unlike all other wearable devices like watches and T-shirts or shirts, whatever other wearable devices, they get non-invasive data. Using a wearable device, we actually call it a FEM wearable category, we get an invasive data. And we can also not only monitor and screen women's health, we can also do treatment, therapeutics. So basically for women's health, my vision is to completely transform their health. We will be able to do even cancer, for example, from a very, very early stage, everything basically.
It's amazing. And tell us how this intervention, this revolutionary product is going to help the environment and how it's eco-friendly.
Oh, okay. So this is also something that's unique about what we are doing. Our device Tulipon, I can show it to you if you are interested.
Please.
So it contains basically two parts, and like any tampon. So one part, like Tulipon, the name of our device is Tulipon, and it's basically what you get when you take a tulip and a tampon together. So that's how we got to the name. And here it is. So it has the applicator and the collecting cup, and this totally dissolves in water. So it's the first time ever a hygiene device will have a flashable applicator. And the cup itself, currently it's recyclable, but in the future we also will be able to do to develop new materials that it's also will be flashable. It's just a question of time and money, but we already know how to do it. So it's going to be, not only it will have the capacity to handle menses, to diagnose biomarkers, but also it will be sustainable, which is something which today it's really important to our world.
That's fantastic. And within the growing interest of personalized healthcare, which we're seeing all over the world now, how will Gals Bio plan this kind of integration between its health tracking features into this kind of broader movement of women's health solutions and personalized medicine and these other future innovations that we're seeing out there? And what kind of innovations does Gals Bio have on its plate for women in the future as well?
I won't share everything, but I'll just say that we have a lot. I'll give you a small, maybe I'll give you a small tip. For example, like nowadays, people discovering that menses contain stem cells, endometrial stem cells. And in some places, some researchers managed to turn these stem cells into cardiac cells. So imagine what a woman personalized can do with her personalized menses. She can collect her menses, keep it. She will have a bank or something that she can keep her menses. The stem cells will be able to be isolated from her collected menses. And then when she needs it, let's say after menopause, she can transfer it into skin tissue. She can do, there are still this is, I'm talking way, way into the future, but we already know today that this can be, this is possible. As for the personalization of diagnostics, for example, as I mentioned, endometriosis, women will be able to diagnose themselves at a very early stage. Cancer diagnostics, cancer cells within the menses, like fertility cancer, 90% of fertility cancer starts with abnormal bleeding. And currently, we are simply discarding it. We are not looking at this liquid. So with Tulipon, they are able to collect it, do liquid biopsy, and diagnose cancer. And this is very, very, of course, it's personalized. It's good for women with BRCA gene mutation. So instead of going through all sorts of surgeries to as a preventive measurement, they will be able to monitor their health on a very, very monthly basis based on their menses. So everything about Tulipon is about personalizations, is leveraging the vaginal cavity, and with the monitoring of personalized measurements, and to give feedback.
Brilliant. And so I always like asking this question because it's so much fun to understand where these innovations are coming from. What was the driving motivation? What was the inspiration behind your product? And then we'll wrap up with this question.
It's a good question. And it's a long answer. And I'm thinking how to give you the short version of it. I've been in the vagina. This company is my second company. I already had a previous company before that, also developing a new tampon that treats dysmenorrhea, menstrual pain. So I got to the current idea while working on the first idea. And one of the reasons I chose this, before that, I'm a biomedical engineer. I studied in Caltech and Tel Aviv University. And previous to becoming an entrepreneur, all I did is cardiovascular. So I worked on a heart assist device with Professor Mori Garib at the Caltech. And when I decided to become an entrepreneur, I had a list of all the ideas. And in cardiovascular, you have a lot of ideas. So it's very hard to be innovative. And one of the ideas was actually about menses. And this is when I was testing for different patents, I like cardiovascular, everything is patent, and walking into vaginal health and women's health, it was like walking into an empty room compared to heart. And so this is what made me decide to step into this void of, but what I didn't realize that the fact that there are no patents, it means that there is also no money and there is no research. But I've been doing this enough time that finally things are changing, and finally women's health is getting attention. One of the examples that I like to give is I have a patent accepted on a new kind of tampon in 2017.
Incredible. That's fantastic.
So almost 100 years after the first patent on a tampon. So this doesn't happen. This is like I'm just, a small person from a small village next to Haifa in Israel. But this is the reality.
Fantastic. Well, Hala, again, great meeting you, great talking with you. Thank you so much for such a tremendous presentation. You've inspired people around the world and certainly here today within our community. Thank you so much.
Thank you. Bye-bye.
What an amazing innovation. And again, would recommend if you're an investor, look her up. If you're a buyer, hospital system or health plan or any kind of clinic, physician, absolutely look her up. And certainly if you're a patient, look her up. I think this is the kind of innovation that we find at HITLAB every day. This is the kind of information, well, not this particular one, but innovations like this are what we're searching for every day and finding and evidencing and helping promote through our community of hundreds of thousands around the world. So greatly appreciated today. Next up, we have another visionary within the healthcare system. I'm not just talking about Ansley Bowen, our own Ansley Bowen at HITLAB, but I'm talking about Lata Sethi, who will be talking about empowering change and being able to disrupt venture capital to support female founders and first-time investors. So with that, again, handing the virtual stage over to Ansley. Ansley, it's all yours.
Thank you so much, Dan. And it is my pleasure to be talking to Lata Sethi, who is the founding investor at How Women Invest Fund. So Lata, it is so great to have you on the program today. I would love if you could give a quick introduction to our audience and we'll get started.
Absolutely. Thank you, Stan and Ansley. Lata Sethi, and I am zooming in today from Nice in the south of France. And part of the reason for being here is my interest in supporting health tech ventures and especially diverse founders. As a quick background, Ansley, can you hear me all right?
Yes.
Excellent. I started life as a bench scientist, subsequently utilized that and my graduate degree in reproductive endocrinology to go to law school and become specifically a trial attorney in patent litigation. I practiced in New York for about 10 years at the oldest patent law firm on the planet, which patented flight for the Wright brothers and electricity for Benjamin Franklin, etc. And after doing that for about a decade with absolutely no control over my calendar or my schedule, and in the meantime, I had gotten married and had a young toddler son that I wanted to periodically see. I left to start my first company, which back then, before the term digital transformation had even been utilized. And so ended up with two different startups. Both got funded in Silicon Valley. And they were fairly novel in their approach, not only to patents and patent law, but generally in bringing businesses and large departments of Fortune 500 companies, including legal departments, up in technology and utilizing and changing the archaic billable hour. Fast forward, my first company was funded by Sequoia Capital, Goldman Sachs, all the traditional top-tier VCs in Silicon Valley. We got acquired 4 years later by Thomson Reuters and subsequently by Ernst & Young. And the second company we started in 2009 got acquired in 2019. Again, Sequoia and Goldman funded that. And the reason I'm providing that background, it's really to give some context on the way that how I was treated versus some of my male co-founders were treated, which was the genesis for what I'm doing now in How Women Invest Funds. But let me stop there, Ansley, and let you ask any questions.
Well, first I want to say what a wealth of experience that you have. I mean, I could honestly listen to you continue to talk about just what your background and your experience has been like. And honestly, my first question was going to ask you, what motivated you to get involved in How Women Invest Fund? And then also, how did you identify that need to really disrupt the traditional venture capital landscape?
Well, excellent questions. I can tell you're listening very closely. Well, two things happened with both my startups. I was a co-founder and had similar, if not even higher, educational credentials, etc., and bought a lot of expertise, domain expertise, funding clients, etc., like most co-founders do. But I think the way I was treated by the, traditional US male venture capital world, and as many of our listeners may know already, 97% of venture capitalists in America are white male brilliant men who generally went to like Harvard or Stanford or MIT, Kellogg, etc., which is fantastic. Unfortunately, what that does is you end up investing in people that look like you, that act like you, that you go to temple or church with or play golf with. And what that has led to happen in the venture capital world is that less than 1.9% of venture capital dollars in America, we're not talking India or Iran or Africa, we're talking America, goes to female-founded startups. And then if you dig a little deeper, 0.5% goes to women of color founders in the US, 0.5, a rounding error, right? And so when my second company got acquired by a large global hedge fund, I was finally positioned to be able to do something of this, cataclysmic differences in the chasm in funding. And that mattered a lot to me at that point in time because of what I'd experienced about 20 years in the entrepreneurial venture world. So I came together with two other women in San Francisco to specifically launch the How Women Invest Fund. And not only do we focus on investing in female-founded startups, I believe we are the largest female fund that invests solely in female founders in the US.
Amazing.
And I came on board as the first investor because I wanted to make a difference and accelerate and support the journey of diverse entrepreneurs. And as you know, Ansley, there's a lot of, fantastic accelerators, incubators, and other communities, including HITLAB, that support founders. But if you don't have capital to invest, you can't build and scale a company. So we launched our first How Women Invest Fund in 2020, right before COVID. Now in 2025, we are on our third fund and we are aiming to raise 100 million for that fund. And we launched that fund ringing the bell at NASDAQ last year. And the distinction I wanted to make sure I clearly shared with you is that we have raised this fund without any institutional capital by bringing in limited partners, primarily high net worth women who are, qualified to be accredited investors, where the threshold for that is pretty marginal in the US. But, women who have historically been successful in investing in the stock market, in real estate, 401k, because either they think you need to have $500 million to invest in venture, or they've never had access to a venture fund. So part of our goal is not only to invest in female founders, and we've already had 2 acquisitions, even though our funds are, less than 5 years old, but it's also to mobilize 10,000 women to invest in our venture fund that have never invested in or had access to invest in startups directly. So does that help explain how we started it?
Yes, and I just want to say that I love everything that you're talking about here. I love, first off, when I feel like people see that there's a problem and then they want to have a solution and then they go out and they solve that problem with the solution. And so you're doing exactly that, but kind of on the opposite end. Typically you would see that from like a startup, starting a company that addresses an issue, but you're instead starting an investment firm to be able to help startups kind of get to point A to point B. And then on top of that, you're recruiting women to be a women-led, women-founded investment fund. So, I mean, honestly, I'm telling you, I could sit here and listen to your experience and everything that you've done for what honestly feels like an hour. I could listen to it. And talking about also, when you're talking like getting first-time investors, right? Because maybe that's a myth that you have to have a certain amount of money in the bank to really be able to be an investor. So how do you help ensure those first-time investors that they, number one, feel empowered and then confident in their decision-making when it comes to investing, and specifically investing in female-founded or led companies?
Well, I love it, and I hope sometime soon you'll be an investor in our Fund 3. There's several parts to that question, so I will unwrap it really quickly. Firstly, as far as bringing in first-time investors, limited partners, as we call them, ours is a venture fund. So what that means is, unlike an angel fund where you invest directly in the startup as an investor, in a venture fund, you generally have an investment council of 2 or 3 very experienced venture partners. In our case, we have 3 women who come from excellent backgrounds in venture investing. And along with our due diligence team, which of course includes me, we make a decision on which companies to invest. So our limited partners are investing in our fund, while our decision making in where and which companies and which founders we invest is made internally within that investment council. But part of the reason I think it's important to bring in new investors, and as you said, to help them understand how to invest. So our fund is called How Women Invest Funds, but we have a partner or sister organization, which is a nonprofit called How Women Lead, where we offer courses in how to be an angel investor, how to be a venture investor, like, Venture Investor 101. It's like a 4-week course. So people who are working or full-time engaged otherwise can learn, because I think it's very important that it becomes part of the conversation, right? So now between our funds 1, 2, and 3, we have over 200 limited partners. So, when those folks go out to lunch or go play tennis or go to the gym or go for a walk with their girlfriends, we want them to talk about, hey, what company are you looking at? What are you investing in? We want it to become part of the conversation. So we have that training. Now, once you decide to become an investor, a limited partner in our for-profit venture fund, once a month, because now when you're a limited partner, you signed off on the NDA and confidentiality and so forth. Once a month, we have 4 of our portfolio companies come online on Zoom and pitch our limited partners, so they become involved in the process and they understand, what do you look for in a startup? What do you look for in a founder? What kind of technology is it? And that also helps the learning process, as well as, you can imagine, they get excited about the companies. And then there's a Q&A and feedback session. So once the founder comes and pitches our broader limited partner pool, then the founder jumps off and the new investors can ask questions to us on what did it work. And we even have a survey as to should we move forward in it, further due diligence, etc. And the other part is, for example, in health tech, we have a lot of subject matter experts, doctors, entrepreneurs, and others in the health tech space who can serve as subject matter experts on our different startups when we're doing the due diligence. I won't dig deeper into that because I know we don't have much time, but those are some of the ways that our founders are connecting with our limited partners, and our limited partners are growing in their confidence to invest. And I just wanted to share one data point on that. So our funds, all 3 combined, have been around for about 5 years total. And last year we did a sort of a research project, a survey of all of our limited partners, and 30% of them had moved on and invested in other funds and become angel founders, meaning that ripple effect, once you invest in a fund and you are believing and supporting female founders, you get excited and energized and confident to do it in other ways as well.
Amazing. I mean, and honestly, you can dive deeper if you want to. I know that we technically have some time constraints here, but I mean, this is so interesting, and I'm sure this is really on point for our audience as well, just in terms of understanding opportunities when it comes to, number one, finding female-led, investments, and then also the classes that you were talking about, like the 4 weeks, and the nonprofit, and just everything that you're doing. I feel like, please do dive a little deeper. Don't feel any
Sure.
not to.
Well, one thing I think might be interesting to your audience is that, investing in female-founded startups, whether in the US or globally, it's obviously the right thing to do because talent is everywhere, right? Opportunity is not. But it's also not just a morally correct or, the noble thing to do. Female-founded startups versus male-founded startups, if you invest $1 in a male-founded startup in the US, you get 37 cents back return of investment, ROI. If you invest the same dollar in a female-founded startup, you get 68% ROI, more than 2x. So as far as whether you're at a family wealth office or you're at a hedge fund or you're in your own venture fund, the point is almost 2 times in profitability for your investors. So it almost becomes a fiduciary obligation if you want to get the greatest returns for your investor, right? And the other part to note is right now, I know most of the audience knows this, but over 50% of college students and graduate students, medical school, law school, MBAs are female. And recently I saw a statistic in the Wall Street Journal, like last week, that over 45% of homes in the US, the head of the household, meaning the primary revenue generator, is a woman. And, when you look at all this combined, women now have the power, the influence, and people like me who are, becoming empty nesters and middle agers, we have had 20, 25 years or more in the corporate arena. So we can bring all those together generationally in a way our mothers and grandmothers didn't have an opportunity to do, to exert our influence and, invest with our, we call it voting with your wallet. Invest in companies that you want to see in the world. You want to be there for your family, etc.
Amazing. Absolutely. I mean, our newer audience is definitely sending up a bunch of emojis. I don't know if you could see, but the clapping emojis and the heart emojis. So they're definitely loving everything. And as me as well as what you're talking about, because I feel like this is so important to learn more. I mean, I had no idea that the rate of return was so much higher when it 2 times the rate, like you said, just investing in a woman-founded company. So, but as we do our conscious of time, I have one more question for you to wrap this up. So in your experience, what are the most common challenges that female entrepreneurs specifically do face when trying to access funding? And then how does your fund actively address and overcome those barriers?
That's a very deep-rooted systemic question. A lot of times, venture firms, as I mentioned earlier, mostly driven by male venture capitalists, they will ask questions for female founders that are more risk-oriented, risk management, preventive questions, while with male founders, they look at it as what's called promotion questions, like where will you scale your company? What countries will you go into? How are you going to grow it? So they are questioned on their potential, while women are questioned on, can you manage this money? Will you be able to bring back the return I'm seeking, so forth. So my advice in one of the clearest ways to address some of the female founder challenges in fundraising is when you're asked that preventive or risk prevention question, find a way to turn it around in real time and convert it to a promotion question. So let's say you're asked about, hey, you have family and you have all these obligations. Do you think you have the time to be able to build and scale this company if we decide to fund you? So maybe the way to respond is, women are very good at managing budgets, at multitasking, and I've gotten here where I am today irrespective of some of the obstacles and hurdles I had to face as a female entrepreneur, both time, finances, culture, etc. And here's how I'm planning to scale. And these are my 2 or 3 milestones I'm reaching for. And I've already reached, X, Y, and Z, and I'm aiming for 1, 2, and 3. And your funding can help me reach 1, 2, and 3. So be on your toes and convert and be aware that these questions can be massaged into ways to highlight the strengths of you as a founder and the areas that your company is really building traction in the marketplace.
Amazing. Again, emojis are just lighting up. I can see it on my screen. And actually, I just wanted to let everybody know that if you're interested in hearing even more about this and a little more in depth in Paris next week, Lata is actually going to be there in person as well. So I'm going to put this up onto the screen here. Again, it is free to attend, everybody. It is at the Hotel Dieu, a beautiful venue in Paris. And again, if you want to hear more for Lata on this, she'll be there in person. And thank you so much for joining us virtually today. And we look forward to seeing you in person next week.
Absolutely. Thank you so much. Have a great rest of the day.
Thank you. So yes, again, everybody, it is free to attend. You just have to apply. We do have a limited amount of seats left here, but the link will be in the chat if you are interested. And before we go on to our next session, I wanted to also open up to do an audience poll. So give me 1 second to launch this up for everybody. And our first question is going to be, how do you feel about the integration of digital tools like telemedicine, AI, and electronic health records into healthcare? Very positive, neutral, negative, not sure. Again, love to get your thoughts. Trying to be more as interactive as we can in this virtual world. So give you all some time to answer that first question while I read off the second one. Which digital tool do you find is the most useful for managing your personal health care? So we have fitness tracking apps, we have telemedicine services, medication management apps, health monitoring devices, or you don't use digital tools for managing your health. Again, really love to hear your feedback on this. This also helps to drive our content for our upcoming symposiums, specifically, when it comes to talking about these fitness tracking apps and medications and telemedicine services that are out there, looking to hear, what's of interest to you. And our last poll question here is, what do you believe is the most important aspect of international healthcare cooperation for improving global health? Is it sharing medical research and innovations, providing equitable access to healthcare resources? Is it coordinating responses to global health crises, examples like a pandemic, strengthening healthcare systems in low-income countries, or promoting universal health coverage worldwide? Again, I'm going to give y'all a couple more seconds to, of course, just fill this out. I know it's a lot to read and kind of think on, but that's what we're looking for, is to get some quality responses from everybody. And then, of course, while you're wrapping up that poll, I'm going to close it in about 30 seconds before we move on to our next session. I just wanted to remind everybody that we also have another in-person event that's going to be in New York from May 6th through the 8th. It is our HITLAB Innovator Summit. It's taking place during New York City Health Innovation Week, where we have a lot of great events that are going on during this week with some, New York companies and organizations. It's a great way to network, a great way to learn more about the digital healthcare landscape and connect with people one-on-one. So if you're interested in the tickets, they are available if you scan the QR code, and I'm sure the link will also be popped into the chat shortly. We would love to meet y'all in person and have as many people as we can. Again, taking that virtual aspect away and meeting you either in Paris or in New York City coming up in the next few months. All right, I'm going to end the poll here, and I'm going to just quickly share the results with everybody so you can look at that. And then I'm going to quickly introduce our next session and kind of hand it over to her. So we have Shweta Patel, who is the founder of Gaia Wellness. She's also going to be in Paris with us next week. So we're going to be giving you a little bit of a snippet of what you could see in person next week. So Shweta, are you on the call with us?
Fantastic.
I can't hear you. Let's see.
Can you hear me now?
Perfect. All good.
Perfect.
Hi, Shweta. Thanks so much for joining us here today.
Thank you for having me. This was really a great opportunity to just be able to share some information about Gaia and what we've been working on there. And it aligns pretty well. So it's good timing, I guess. The universe, as you say.
Well, thank you so much for hopping on the call. I just made you co-host, so feel free to share your screen.
Okay.
And I'll hand over the virtual platform to you.
Awesome. I'm just going to take a second to load up. Sharing my screen. All right. And everyone can hear me okay, right?
Yes, all good.
Rehumanizing healthcare through AI. Hi, everyone. My name is Dr. Shweta Patel, and I am a board-certified OBGYN, as well as the founder of Gaia Wellness, a virtual-first model that's reshaping personalized healthcare for women. I'm also an ardent advocate for tech-enabled human-centered care solutions, and and this is also how you can reach me. This is a QR code to my Linktree. So if you do want to talk or connect after this, I would love to hear from you. And so, though this talk may be about digital tools and how they are transforming healthcare, I wanted to start off with a very deeply human story. To start, not long ago, I was on the phone with my sister, and who she's also a physician, by the way, and we were swapping war stories as we often do, stories that are full of compassion and grit, but also fatigue. And she's one of the good doctors, you know, the kind that you kind of hope is on call when you're hurting or you're scared. And she's been sharing how she's been feeling tired of her work-life balance and of how the healthcare system just seems to be not working more and more so. We also talked about like previous shifts and patient relationship and how that's looking, etc. And we kind of also talked about how much we both rely on ChatGPT. So much so that I jokingly refer to it as my boyfriend or husband sometimes, depending on the day. Why? Because ChatGPT listens and it learns. It meets my needs with a level of attentiveness and adaptability that honestly rivals some of my real past relationships. It may also be the reason why I'm single. Just kidding. And so, as odd as it sounds, that's when it clicked for me. AI, when used with intention, isn't a threat to the doctor-patient relationship or the healthcare system. It's actually the thing that might finally give us the space to rebuild it. So we're living in a remarkable inflection point in healthcare where machine learning is no longer a hypothetical disruptor, but an applied catalyst driving precision, access, and personalization across the care continuum. Over the last decade, digital health has matured beyond dashboards and data visualization. We've seen AI-enabled diagnostics, remote monitoring that rivals the brick and mortar care that we have. We have large-scale investments in virtual first care models. Tools like ambient voice technology, large language models, and predictive analytics are fundamentally changing the way the clinician and patients interact. Yet, the real transformation isn't happening in isolated algorithms. It's in how we translate these tools into scalable, patient-centered experiences. Because while AI might understand clinical intent, the real challenge and opportunity is in applying that intelligence where care begins, the moment the patient raises their hand and says, "Hi, I need help." And that's where Gaia Wellness comes in. Gaia Wellness is a virtual-first women's healthcare platform that transforms virtual urgent care visits into long-term personalized wellness journeys through high-touch integrative care. So we asked, what if virtual care didn't start with a form, but rather a conversation? You know, many telehealth solutions today remain transactional, and patients complete a static intake form. There is usually delays in care. There may be loss to follow-up, but healthcare doesn't necessarily thrive in that format. It thrives in nuance and dialogue and connection. So at Gaia, we asked, how do we use AI not just to optimize operations, but to bring back intimacy, to scale care, not just clicks? We reimagined what a visit could feel like from the first question to the last follow-up. Here's what that would look like. A dynamic express visit engine, which instead of a static intake form, engages patients in real time with our AI agent. It's warm, it's responsive, and it does more than collect data. It clarifies and confirms, mimicking a true conversation. No two dialogues are exactly the same, and that's by design. Our dynamic express visit engine then is able to generate visit summaries in the form of SOAP notes, autofill labs, imaging and prescriptions, handle billing codes and clinical documentation, and also set up personalized guidance as follow-up. We, of course, have the human element or partnership where a physician is or a healthcare member is actually verifying all of the work that's done by our AI agent and ensuring that it is accurate, as well as giving the AI agent an opportunity for learning to improve its accuracy with each output. And then care delivery in the form of, like we said, prescriptions, labs, imaging orders, and a detailed care plan that's in a language that's understandable to that patient specifically, delivered within minutes. And of course, personalized patient follow-up journeys. Of course, the future of digital care is continuity. And so once a visit concludes, our system segments patients into tailored health journeys, whether it's hormonal balance, weight loss, or contraception, etc. Each patient receives a curated path of content, follow-up, and product recommendations based on their needs, preferences, and goals. This is care that evolves with the patient. It's care that remembers. In essence, we're restoring the rhythm of relationship-based care, but at scale. And what else? Oops, didn't mean to do that. One of our most exciting projects is a predictive preventative care tool. Imagine this. Based on age, history, and risk factors, the system builds a preventative screening schedule tailored to the individual, and with one click, it syncs directly into her calendar, whether it's Google Teams, Outlook, or whatever. No more forgetting mammograms or pap smears, no more wondering what or when it's due, just proactive, automated, personalized care. We often hear the fear that AI will dehumanize medicine, but I believe that's actually backwards. At Gaia, AI is being leveraged to extend healthcare's reach. AI clears the clutter to make care faster, smarter, more empathetic. It creates a space for us to reconnect. It's not about flashy tech, it's about reviving what matters. A provider who knows you, a system that supports you, a care journey that grows with you. AI is helping us rehumanize healthcare. Looking ahead, next month, which I thought that was a mistake, but I guess it's accurate because it is April and we're already at the end of this month. But next month, I'll be sharing the story on a bigger stage at HITLAB BTA Summit in Paris. The talk is going to be titled AI AIO, Bridging Women's Healthcare Gaps Across Borders. We'll be expanding on everything that I've discussed here, and I'll also be diving into exactly how we take these innovations and translate them globally, from the US to Europe and beyond. Because women's health is not just a national issue, it's a universal opportunity. And AI is the exact connector we've been waiting for. Thank you for listening. And if this resonates with you, whether you're a founder, a funder, a physician, a patient, or just somebody curious, I would love to talk. We're not just innovating, we're reclaiming the heart of healthcare.
Thank you so much, Shweta, for your presentation. And yes, super interesting. We had a lot of comments as well in the chat about how ChatGPT may be actually better than a boyfriend because it listens. So I love that little first start that you have to get everyone's attention. And yes, as you mentioned, you'll also be in Paris next week. So again, if anyone is local to the Europe area or Paris area, please do apply to attend so you can get more great presentations and talks like you've heard already today. So thank you so much, Shweta, for being on the call with us today, and we look forward to having you next week.
Thank you so much for having me.
Thank you. Alrighty, and we are going to go on to our next couple of sessions for the day. We are going to have our global director, John Hammett, who is going to be speaking with Subrata, who is the Vice President of Diagnostic Imaging, Data and Artificial Intelligence, the Head of General Clinical Imaging Services at Bayer. And then we are going to also hear from John and then Alice Zing, who is the partner of Foregrown Capital. And before I hand over the mic over to John, again, I just wanted to quickly remind everybody about our Paris event coming up. Again, it is free to apply to attend. The links are in the chat. We also have our Innovator Summit coming up in May. And that would be a great event for you to also attend in New York City locally, which is taking place during New York City Health Innovation Week. And again, tickets are available online as well as in the chat. And before we hop over to our next session of the day, I know that we have our global director with us, John, here. So hi, John. How are you doing?
I'm great. Thank you.
Thanks so much for joining us here today, John. I know we're just kind of waiting on Subrata to be able to log in, maybe having some technical difficulties at the moment. But in that time period, John, would love if you could maybe share a little bit more about what you do at HITLAB.
Well, I do almost everything from sweep the floors. That's a joke because we're largely virtual with limited office space, but to really help some of our sponsors better understand the questions they're trying to solve, or the issues they're trying to solve, and the questions we can help them answer in providing those solutions. And so it's crafting the strategy, the scope, the scale, and the speed at which we can answer the questions, because we live in a world today where speed is as important as anything else. It's not just simply the quality of the answers, but how quickly you can get the answers, because 6 months from now, the world will have shifted. There's a new technology vector. There's some new insights. There's some new scientific breakthroughs. And so speed and quality have to go hand in hand. And so one of the things we try to offer the sponsors of our work is both, a quick solution, a value-based solution in terms of cost, and more importantly, a rigorous solution that could be published and stand up to the rigor of investment challenges or the issues associated with diffusing in the marketplace. And so I suppose my greatest influence is encouraging everybody to work good, work fast, and give our sponsors value for money.
Well, thank you, Johnny. We know how much you do for HITLAB, and it's always a fun to hear you talk.
By the way, I do have a broom.
And if anyone's interested as well, we will be putting John's LinkedIn in the chat so you can connect with him one-on-one as well. And we are still waiting for Subrata to be able to hop on, again, having some technical issues. So in the meantime, I'm going to give an opportunity for some more people who may have joined us to answer the poll question. So I'm going to relaunch this poll really quickly. Again, just trying to see any feedback that we can have from y'all. This really helps to feed our content moving forward. So I'm going to quickly read over some of those questions for you. How do you feel about the integration of digital tools like telemedicine, AI, and electronic health records? And actually, John, while we have you here, maybe I'm going to put you on the spot and have you answer your poll questions live.
Well, from my point of view, it's positive, but more importantly, exciting, because frankly, whatever we imagine, the future will be above and beyond that. It'll be different. It'll be broader. It'll be more significant. It'll be in directions that we can't imagine. And so, in a sense, we need to move as quickly as possible to understand what today's capabilities allow us to do and get on with the job of doing, because doing is also discovering. And so, in a sense, we want to proceed, as I said earlier, with speed. So I'm very optimistic about the future. And when we hear people like Sweta, who just recently redefined, if you will, the way medicine can be delivered on a personalized basis and on a humanized basis with a dose of technology to help the intelligence of our physicians and medical practitioners touch a patient, deal with the patient's needs. I mean, that just reopens in my mind the enthusiasm for let's get on with doing more and better. I'll give you a couple of simple anecdotes about the dilemma with medicine today. A family member has recently found that some of the therapy they were under for a gastrointestinal problem was not working, and as a result ended up reaching out to their specialist, and the specialist prescribed a couple of diagnostic tests. Those tests had to be scheduled 3 to 6 to 7 weeks out because the diagnostic facilities were backed up. So this person was not satisfied with the need to wait, and so they essentially went to a different provider, a well-known provider based in Minnesota. You can pick the name yourself. And as a result, they not only saw a new physician on short notice within a week of scheduling, and while in the midst of that diagnosis with the physician, they scheduled imaging and other testing that were done within 24 hours. So I look at that and I say, that's two versions of medicine. That's medicine the way it used to be and the way it is. And that's medicine institutionalized with a sense of speed and quality, which that provider is well known for. And so it's not just simply people like Sweta who are redefining the nature of healthcare at the level of primary care or OBGYN or other what I'd call deeply personal levels, but also there's very large institutions which are trying to streamline the understanding of need and then come quickly to a conclusion about what kind of solution or therapy would be useful. And so that makes me very optimistic. I think technology, the integration of technology in provider systems and the integration of technology at the level of hands-on care, are going to truly transform the world for us in the next 5 to 10 years. And so I'm anxious to stick around and see it happen.
Well, and 64% of our audience agrees with you that it is very positive and that they believe that it'll improve access to quality of care. And kind of going on to the next question here, I'm going to put you on the spot again. So which digital tools do you find are most useful for managing your personal health care? I know that you are big on wearables. You have the Oura Ring. You also have Apple Watch. So I'm assuming I know where this is going to go, but
you opened up an answer that will take longer than we probably have time. I am a well-measured person, so I do wear a ring. I wear multiple rings because actually I'm so intrigued with the biometrics associated with the devices that every time a new one comes out, I kind of lay down the money and give it a try. I do use the Apple Watch. I also use other forms of what I'll call biometric therapy as well. So I'm an advocate for using devices to understand what's going on within your body. And so that's important. But number two, to take a look at how the data is being interpreted and personalized for you. And so, and interesting, and you heard me about this at our last summit in New York. I was talking to one of our cardiologist friends who was focused on sleep as a dimension of improved cardiology health or cardiovascular health. And he was using the Apple Watch as an example of a monitoring device that can measure the quality of sleep. And so I said, aha, all right, I have a device, I have a ring. So I have two different sources of the same basic data, which is heart rate variability, temperature, blood oxygen, etc.
Right.
So I wake up in the morning and the ring says, you had a lousy night's sleep. You only had 3 minutes of deep sleep. So I go to the Apple Watch and I use 4 different applications to analyze the Apple Watch data. And I get now 5 different answers, anywhere from 3 minutes of deep sleep, not very therapeutic, John, get better sleep tomorrow from the ring, to one of the apps that says you had 3 hours of the most restful sleep you've ever had. Good to go, buddy. So what does that tell us? That tells us first, we can measure what's going on in our body, but we have to learn to look at and understand the underlying algorithms associated with the analysis of the data and the conclusion those algorithms are providing. Every one of these applications and every one of the devices are well-intentioned, and they're very accurate to the extent that they've done all of the due diligence of the technology. But what we need to understand as consumers of the recommendations is, how are they coming to that conclusion? Because if I wanted to, get more sleep, I would listen to the ring. If I wanted to get, if I wanted to stay up later and watch one more episode of something I was binging on and get to sleep later, I would trust, the best answer in the watch. And so it's just a curious anomaly of today's world where we're being flooded with opportunities to measure, and we've got to learn also to trust but verify the feedback we're getting. So that was more than you wanted to know, I'm sure.
No, I mean, again, John, I love talking to you because you're always a wealth of knowledge, and it's a pleasure to talk to you with stuff. And I know that poll question specifically, when I created it, I was like, John, this is a John question because you are so interested in learning about the different types of wearables that you would call them and what they do and how they interact and which one's better and all of the above. But looks like we do have our next guest up on the call today. So if you would just, Subrata, if you would please just accept that panelist invite, and we will take you backstage and set you up to talk with John here. And he's on now. So I'm going to hand it over, John, to you to take it over.
Thanks, Ainsley.
Hi, John.
Hey, how are you?
Not too bad.
Well, thank you for taking the time to be with us. It's a interesting time in the world of healthcare, and it's an interesting time specifically in the area of diagnostics and the use of AI in diagnostics. And given your position in diagnostic imaging and the data and artificial intelligence within Bayer, I'm curious, what are you seeing as some of the challenges? As we've seen for years, technology has been well advanced in the use of imaging and the analysis of imaging and radiology. So I'm curious how AI is changing and possibly even accelerates that insight.
Thanks, John. Modern imaging technology produces approximately over 5 times more images per scan than a decade ago, creating huge amount of interpretational burden to radiologists. In a recent survey, it emerged that over 46% of radiologists reporting burnout, and most alarming, estimated 40 million diagnostic errors occurring per year in radiology globally. So you can imagine the compound challenge that the industry is facing. Now, obviously, technology, particularly AI, can offer promising solutions to these challenges, to address some of these challenges. For example, some of the AI-powered triaging system can prioritize work list. Some of the administrative work can be done through algorithm. So the workflow optimization is one of the key areas where AI has been making an impact. So basically, AI can automate some of the time-consuming tasks like measurements, comparisons with prior studies, some of the note-taking, and so on. And this automation would allow radiologists to focus on their expertise on complex interpretative tasks. So where they would need sophisticated human skills and then repetitive mechanical processes. So there are promises. Quality assurance represents another valuable application. We believe AI system retrospectively analyze reports and images to identify potential missed findings or inconsistencies, creating a kind of net that helps reduce diagnostic errors while providing continuous learning opportunities.
So I'm curious, and this is only because I'm not that deeply familiar with the technologies of AI as applied to radiology, but in the process of developing the AI intelligence, I'm assuming there's a training process, and the AI intelligence has got to be trained on images that have been reviewed by physicians in advance. And so I'm curious, as how close are we to the AI being good or better than the physicians and the images that have been used to train?
I think developing software medical devices with AI is a complex process, and the objective should not be replace the medic. The objective should be support the trained clinician with their job. In terms of development, there are many challenges in terms of developing software as medical device. You can imagine, unlike conventional software where the logic flow is explicitly programmed, AI systems develop their own internal representations that can difficult to interpret. The other challenges we see is data quality and availability. That represents perhaps the most critical challenges. We see that approximately 80% of AI projects face due to data-related issues. Even more striking, over 80% of the development time is typically invested in making data algorithm ready, including defining the data specs, finding appropriate data sets, performing quality checks, and complete the annotation and labeling. So all these tasks would need human intervention and expert clinical expertise and technical expertise. regulatory compliance is pretty challenging. Global regulatory bodies are evolving their framework to address AI-based medical devices, particularly the challenges we face around adaptive learning capabilities and so on. And then there is a technical and clinical validation challenge we face because traditional software validation approaches do not adequately address the AI system that may evolve over time. For example, how do you validate a system that might deliver different output as it learns in a real world setting? So overall, it's evolving. There are huge opportunity we see. At the same time, there are challenges that we need to address. For example, the black box problem of AI. Many effective AI algorithms with deep neural networks involved operate in ways that are not easily interpretable by humans. So, particularly in healthcare, explainability is a crucial factor for clinical adoption and building the trusts to make sure that we have got the trust on the algorithm. But overall, there are good progress has been made.
As you were explaining that, I had this strange perspective, and so I'm going to share it and see if you've got your own thoughts on it. Today we're in a world where the experts in radiology, the trained physicians, the people who've got 10, 15, 20, 30 years are training the AIs. At what point do the AI capabilities begin to train the physicians of the future? I mean, there's potentially a sharing of knowledge that ultimately is going to come back and augment and change the way in which we train radiologists in the future. I'm wondering, first, is that a reasonable thing to think about? And secondly, at what point does that crossover take place?
It's a very difficult questions to answer in terms of the timeline. I think over the time we need to make sure that the way that we are training the algorithms, the way we are bringing a diverse data set within the training framework have been augmented. By that I meant within the training of AI algorithms, we need to bring in diverse population. We need to bring in a diverse data sets generating from diverse set of machines. We need to ensure the data are curated, data are leveled, and data are prepared in an ethical way. And we need to ensure that the expert clinicians are involved and expert technicians are involved in terms of the preparation of the data requirement, in terms of finding out in terms of defining the endpoints. What would be the endpoints in terms of setting up the metrics, the right metrics, and also the validation framework is very important. So there are two types of validation framework that is very important. One is the technical validation, and the other one is the clinical validations. So with technical validation, you would like to ensure that your algorithm is producing the classification rate that is expected, that is better than the existing diagnostic framework, and what is the cost of misdiagnosis. And then you need to make sure that there is a clinical validation in place, meaning that rather than testing the algorithm within a controlled environment, you are deploying the algorithm within the real world setting, and then you are seeing the performance and continuously augmenting the performance. I think we are at the right path. Technologies are evolving pretty fast. However, there are barriers, particularly bringing in diverse data set, bringing in diversity, bringing in quality within the training data set. So here we are talking about human health. When you train an algorithm, you need to make sure that the algorithm is learning with the right annotation and labeling. This is not the case in many industries. For example, if you'd like to create algorithm for autonomous vehicle, you may train the algorithm with objects. For example, another car, different sizes, trucks, different human beings, red lights, yellow lights, and green lights. So you need some expertise, but you do not need years of technical expertise. Whereas if you like to create an algorithm that involves anatomical knowledge, clinical knowledge, then you need to bring in the right people. And these are not easy. These are very complex to bringing the right people at the right team with the right anatomical knowledge, clinical knowledge, regulatory knowledge, and so on. However, as I said, that there is a huge demand from the healthcare around the globe, and we see that the organizations, companies, regulatory bodies are working together to find a sustainable and a robust system.
You triggered an interesting thought, which is we're in a world where each of us is an N of one when it comes to our health and our diagnosis, et cetera. And more importantly, all of the N's are different. Some are a little bit different, and some are a lot different. And so in the world in which AI and other forms of software as an application, software as a medical application or a medical device are being developed, how do you ensure transparency and fairness across, what I'll call the variety of the individual, and yet what I call the ubiquity of the technology to analyze all of those differences? How do you ensure that is both a transparent process and a fair process?
That's an excellent question. So ethical landscape is complex and evolving very rapidly. So there are algorithmic bias that represents perhaps the most pressing concern, where the AI system are trained on data that does not adequately represent a diverse population. As scanners, as I said earlier, they can perpetuate or even amplify existing healthcare disparities. The data preparation challenge is directly linked with some of the ethical concerns. So with over 80% of development time dedicated to data preparation activities, as I mentioned, it involves defining the data requirements, finding the right data source, quality controlling the data, doing the annotation, doing the labeling, and there is significant risk that shortcuts in this process could introduce or amplify biases. So organizations must recognize that investing in proper data curation, data infrastructure is not just a technical necessity, but an ethical imperative. Patient autonomy and informed consent present another ethical challenge. So when AI systems influence clinical decisions, patients may not fully understand how those recommendations are generated, or what are the alternatives that may exist. So to address those concerns, developers should implement bias detections, for example, and mitigation strategies throughout the AI life cycles. It can include diverse data collection, algorithmic fairness metrics, regular audits for unexpected biases, and then transparency. You asked about transparency. I think transparency can be enhanced through appropriate level of explainability, and this is very important. So not every decision needs to same level of explanation, but critical diagnostics or therapeutic recommendation should be accompanied by interpretable rationales, for example. So the concept of contextual transparency are in place that offers a framework for determining the appropriate level of explanation. So I think overall inclusive design practice is important, meaning that diverse stakeholders include patients from underrepresented groups in the design and testing process, helps identify potential issues before deployment, and all the technical stakeholders involved in terms of the development life cycle come up as a team to address some of this.
So as we wrap up, we've just got a few minutes left. I've got a thought or a question around personalized medicine, and I'm going to create a little context for it. 5 years ago, I was at a personalized medicine conference, and it was right around the corner. I mean, 300 people, all representing a variety of disciplines across healthcare, excited about the prospect for personalized medicine, and the conclusion was, we're almost there. Well, 5 years later, we're almost there. So personalized medicine has moved more slowly than we had guessed and hoped, number one. But number two, in a world, and you represent certainly a deep body of insight about the use of AI in radiology as an improvement in the diagnostic process, at what point in the personalization of that diagnosis do we need other information to give me a full insight? I mean, so I'm imagining I'm going to step into a device 5 years from now. It's going to take a picture of something, and it's immediately going to tell me what it sees. What more does it need to know about me to make sure that I have a personalized view of both my problem and a solution? So because it's more than just that point in time.
Yeah, personalized medicine is a huge area where we see that integration of AI medical software creating unprecedented opportunities by enabling analysis of complex, often multimodal data set at scale. So this capability would allow us, or allowing us, for more precise patient stratification and tailored intervention. That's one of the core premise where we believe that AI and technology would impact. For example, in oncology, AI systems are already demonstrating remarkable abilities to predict treatment responses based on molecular profiles. So there are AI systems that predict treatment outcomes for cancer patients with greater accuracy than some of the traditional methods by integrating genomics data with the clinical variables. For chronic disease management, AI-enabled monitoring through wearable devices transforming care models. So there are works ongoing in diabetes management and other areas where system can provide personalized dosing recommendations that adapt individuals' metabolic patterns, for example. However, as I mentioned, there are obstacles, and data, unfortunately, is one of the key obstacles because success would depend on integrating diverse data types across multiple systems. Unfortunately, organizations pursuing personalized medicine applications are struggling to get diverse data set as it is sitting on different systems. So it means that the data infrastructure and curation capabilities needs to be augmented. Data interoperability is another major barrier. We know that there are progresses with the standards, but still, when it comes to the interoperability, it is a challenge. And the other challenge is the integration within the workflow. So most sophisticated AI algorithm may have limited impact if they don't fit seamlessly within the clinical workflow that operates. So overall, I think there are challenges. The other challenge is reimbursement models that have to keep pace with the innovation that we see. So many personalized medicine approaches enabled by AI don't fit neatly into the existing payment structure. So, and it does create some barriers even with the proven technologies. So finally, I think the challenge is demonstrating the overall clinical utility. But overall, the trajectory is promising, and that's the key.
Well, this has been a fascinating discussion, and Ainsley, take note, we needed more time.
Noted there, John.
Thank you very much. Enjoyed the conversation.
Thank you.
And now we're going to have a conversation with Alice Zhang, who's a partner with Foreground Capital, and hopefully there she is. Welcome.
Great. Thank you for having me.
Well, you're quite welcome. Thank you. And as if you were listening, you could see that these don't always follow the plan to fit in the time. So we'll have a conversation for interesting things as long as it takes. How's that? I promise. Tell us first a little bit about Foregone Capital. Just who do you represent, and what's the thesis, if you will, of your group? And then we could talk about you and your journey.
Sure. Yes. And thank you again for having me and elevating the topic of women's health. That's really my life's work, and very excited to share more with this group today. As for Foreground Capital, we are an early stage venture capital fund that's investing exclusively in women's health. By women's health, we define that as areas that are specific to women, different in women, and affecting women disproportionately. And we invest across all healthcare segments, including the life sciences, as well as health services, health tech, digital health, et cetera. We actually spun out last fall from RH Capital and are still managing RH Capital's Fund 1 and 2. So in total, we have about 23 companies we've invested in, including one exit, which makes us one of the largest women's health portfolios out there in the venture capital space.
Well, thank you. That's a nice synopsis, and I appreciate it. The thing that I'm most curious about, and I'll put it in context, at every point in my life, as I sort of stopped and took stock of where I was and what I was doing, I was always surprised where I ended up. And so in a sense, my philosophy today is I'm where I'm supposed to be, even though I didn't know it. So
love that.
So I got to where I needed to be, but I didn't know that I was there during the journey. So that's the context. You've got a really interesting and diverse background in clinical medicine, consulting, and global health and venture capital. So you've had an interesting journey as well. And I'm curious about how that journey and your specific insights and experience have shaped this perspective on women's health.
Sure, absolutely. And I love what you just said. I don't think I would have ever imagined being in this position 20 years ago. When I was in college, I was very much skeptical of the private sector and really wanted a career fully in public health or medicine, and did not have to be here. So I completely agree with what you just said. If I look back at my journey, in many ways, I'm a very curious student. So when I was in public health and medicine, I was curious about the business sector and jumped deep in there. And then when I was in consulting, I was curious about venture. And so there's just been a series of different changes and pivots, largely driven by, I would say, curiosity and curiosity, I would say, just around how else can we leverage different tools to make an impact? I would say what is the consistent driving force is a notion around how to serve underserved groups, whether it's using a public health tool or using a clinical medicine tool, or now, as a venture capitalist, how can we leverage innovation and funding those innovations to drive change? And also what I'll say is within that, I've always been drawn to underserved groups. So in my public health days, I was working in East Africa, without running water at times and no electricity. And women's health is that underserved issue within the private sector. It's an area that has been historically underfunded, underinvested in, and yet has significant need, both clinical need and large populations. And there's also a component of gender equity. So all of that makes it very exciting. To answer your question on how have those different perspectives shaped my thoughts today, absolutely. I bring all of the different hats into my work, evaluating and supporting innovation. The clinician perspective allows me to read clinical papers and scientific papers and understand them and speak that language, and also have the mindset of how a clinician might think about adopting new technology and what are the uphill battles these clinicians are facing in the status quo. As a consultant, I worked with many Fortune 500 companies in women's health and beyond, and so have sort of that language and that perspective around how are those big companies thinking about innovation and women's health. And other perspectives, such as the public health experience, help me think about taking a step back from the business side and the financial return. What does this actually mean for healthcare more broadly, and the impact on individual lives as well as at the population level? And I've also had the patient lived experience as well. And I don't think you have to have a lived experience to invest in a sector, but certainly it gives me a different perspective. And there's certain areas that I will just have a little more just deeper experience in as well. aside from those different perspectives, I would say network is a big piece of it. And for anyone who's, traversed different terrains in their career, I'm sure you can appreciate that the networks in different places, it's great to bring those along with you because, in any given role, in any given space, those can be very helpful, such as my medical school friends. They're all different specialties now. I can reach out to them and ask different questions about what they're seeing and how innovations relate, et cetera. I'll pause there.
Well, so I love your enthusiasm and your passion. Thank you. We are all recipients of healthcare. In a sense that and I grew up in a world where healthcare was fix me when I'm broken. I didn't think much about it. I didn't take care of myself. All I knew is that when I needed help, I could go get it. So I'm curious if your experience as a patient has influenced your perspective and focus on advocating for women's health.
Yep, absolutely. I have again, not planned, experience many different parts of women's health as a patient, and that includes everything from infertility to difficult pregnancies to pregnancy termination even. And I would say the biggest shock I had as a patient was just how little I understood about the patient experience, even though I was a provider in all of those same areas. I had actually done extra rotations to learn even more about each of those spaces. And yet there were many parts of the patient experience that I did not expect and was never taught in medical school. And what I realized is when you're in medicine, you're taught to treat the areas that have, lasting morbidity, mortality, kind of like, serious medical impact. But the patient experience, there's a lot more to that. There's things that that may or may not happen that have a big change on your quality of life and your mental health, but your clinical provider may not be focused on that because it's not, driving the, clinical outcomes. So that was definitely a shock and a learning for me and does give me more resolve and commitment to the women's health space. I will say that I was committed to the space even before that, before the experiences, just on the grounds of unmet clinical need, business opportunity, gender equality and all of that. And, one thing I do want to highlight is, women's health is important for many different reasons. And I do think that the conversation is shifting in good ways. There's a lot of really important impact that we can have within women's health on entire societies and health systems and, women and their families and all of that. And so there's a lot of those reasons to be in women's health, but we shouldn't miss the point that is also a business opportunity as well. And I say this because sometimes I meet men who are in the space and they're a little bit apologetic. I don't have the experience, that's how they feel. But actually, I say, you don't have to have diabetes to invest in or innovate in diabetes. You don't need to have cancer to invest in oncology. These are areas that people universally recognize as clinical opportunities, financial opportunities. And it's the same for women's health. So it's a cherry on top if there's lived experience and there's that kind of deeper kind of personal commitment. But I absolutely do not think it is it is not necessary. It is nice, but not necessary for both innovators and investors.
Well, you're an extraordinarily passionate advocate for women's health. I mean, and that comes through even in the kind of the limitations of virtual connectedness that we live in today. And so your excitement for the field is contagious. I'm curious, what changes do you hope to see in the next 5 to 10 years that will be specifically useful for women's health? Because you made a very good point that there are gender specific and gender different needs. And so I'm curious what you see as the next 5 to 10 years bringing and how that's going to begin to get a little balance.
Yep. Yeah, I would say, women's health has come very far in the past, call it 5 to 7 years, where innovation has really taken off. And I expect and would love to see that continue. And I mean that in a few different ways. There's been much more increased public awareness, and that's been really exciting to see across all area of women's health. And I do think that it is expanding. In the early days, the conversations were very much around reproduction, meaning fertility and maternal health. Menopause became a very hot topic over the past couple of years, which is something possibly unimaginable to some who weren't even able to talk to their doctors about it. That's changing, and where I see women's health going in the future future is the conversation expanding even more beyond female-specific conditions, as in, women's biology, but really other things that affect the health of women, such as heart health, autoimmune health, and lots of these other areas that actually drive significant morbidity and mortality among women. So that kind of awareness and conversation is one shift that I see. We've seen a lot more investment as well in women's health. Of course, this is against the backdrop of a boom in VC, and now we're in a correction phase. So women's health is facing the same tailwinds that the rest of healthcare innovation is facing. I have hope that we have hit the bottom of that and we're on our way back up. Just anecdotally, I'm experiencing that, and we'll see what PitchBook and other sources say about investment levels overall. But my sense is, hopefully we're kind of turning the corner now, and so in 5 to 10 years, I very much expect to be in a different part of that cycle. And I don't know that we'll ever reach 2021 levels of kind of the COVID. Observe like low interest rate era of innovation and investment, or of investment. Not that innovation will not rise, but the investment piece of it would really peak then. I don't know if we'll get quite to that level, but I do expect to be in a different place than where we are right now. And that also means, more and more startups being formed, tackling these really important issues, and more investors as well. 3 to 5 years ago, there were very few funds dedicated to women's health. We are one of the few. There's a growing number now of specialized funds, as well as funds that are spending time in adjacent areas like care economy or all things women, as well as generalists. What's really important is that these larger generalist funds that can write the later stage investments are also spending time here, and I only see that growing as we continue.
Thank you very much. And again, your influence is very, very much needed across the world of innovation and healthcare, and specifically your focus on women's health. So I want to thank you for that, number one, and say, Ainsley, one more time, we needed more time.
Thank you so much for highlighting this topic.
You're
and if
quite
anyone wants
welcome.
to connect on the topic, please find me on LinkedIn. I'm all ears.
Great. Take care.
Okay, thank you.
Well, we're going to continue our conversation about innovation and healthcare by bringing up Lernek Essi, and she's a leader in healthcare digital health strategy at Canon Ventures. Welcome. Good to see you.
Yes. Hi, John. Great to be back.
Good. Well, why don't you give a little brief on Canon Ventures and what makes you folks unique, and then we can begin to talk a little bit more specifically about population health management, which is one of my favorite topics. So.
Absolutely. Canon Venture is a venture capital company it's a boutique venture capital company that particularly is investing in startups that are coming from disadvantaged background, countries with disadvantaged background economically and sometimes even politically. So we have been investing in countries, particularly in Eastern Europe, that either they have been just coming out of a war, or they are in the war, or they have been affected with natural disasters, and the startups coming from there that have a health, specifically health and population health, particularly innovation solutions. We have been investing on them.
So as a leader of the digital health strategy at Canon, I'm curious, what aspects of innovation do you see as having the greatest leverage or the greatest value in terms of population health management?
Yeah. So I will just start by saying that mentioning the population health, what is important, and what I have been hearing all the speakers speaking about it is addressing health disparities. And that is the main goal of the population health, as we know. And the way I see it is addressing it in 2 major steps. And the first major step is identifying where is actually the disparity. And the second step is how to address it, how to find the very right solution for that particular disparity and whatever is causing that disparity. Both of the steps has been the main focus of my efforts that I have been leading over last almost a decade in my engagements in innovation and healthcare, that for the very first question, I will just drive us through one example that it will picture these two steps very clearly and how we use innovation. So we were tasked by identifying the reasons behind high number of patients with high blood pressure in certain geographic location, and we used different type of data, very advanced analytics, different machine learning models, to basically dissect the data that we got from that geographic location, dissect it further and further with different drivers of the high blood pressure. And sure enough, to our surprise, we found out the environmental factors such as access to pharmacy was the big driver for one particular area, geographic area, that was driving a high number of missing the refilling the medication or being compliant with their care plan due to the medication, lack of medication. So what helped us, speaking of innovation, what helped us was relying on that data and advanced analytics to come up with answering the first question, which was, where is the disparity? And then we spend a lot of time with our interdisciplinary teams to come up with a solution that fitted specifically to that population and addressing their pharmacy needs. So we came up with this automated medication dispenser that in a secure way through an app, patients could access it in a easy and more realistic way. It was 30 minutes commute on average for patients to get to that dispenser and get in a secure way, get their medications dispensed to them. So in the second step, using that agile innovation solutions has absolutely helped us to come up and design a solution that fits specifically a reason that was driving the health disparity outcomes for that population. And just to summarize, I want to definitely highlight what innovation has done was it has been driving a shift towards more proactive, data-driven, and also personalized care. That's what we are seeing, and I have heard other panelists also talk about that personalized medicine, and definitely that touch has changed outcomes for population health. But one thing, last note I want to make under this topic is, as a leader, because you mentioned specifically being a leader in this role, I think we are so much focusing on adapting AI and innovation. And what is very important is being a leader that is regenerative, meaning we are not just implementing the AI and innovation in a one silo efficiency, driving the efficiency, but to look at involving that innovation and maintaining that efficiency as a system and for our human factors also.
It's interesting, you've got some time spent at Memorial Sloan Kettering Cancer Center. And so first, thank you for what you did there while you were there, because I've got a number of friends and family members who were all successfully treated by Memorial Sloan Kettering. Basically New York, but they've got other locations as well. So you've helped make it the respected institution it is today. But how did your experience there actually help form and you were working in clinical operations, as I recall, virtual clinical operations for population health. How did that help reinforce your perspective today?
Yeah, absolutely. And thanks, John, for mentioning. It has been an honor to work at Sloan Kettering, and it's one of the leaders, if not the top leader globally for cancer treatment. So definitely has been an honor, and it has been more honor because specifically during, I joined the team during COVID, and there was a big interest to build that virtual platform to improve access to care for cancer patients globally. So I was particularly driving the efforts on building the clinical operations virtually to improving access to care. And I'm sure you have seen the numbers. Unfortunately, we have annually almost 2 million new incidents of cancer, which is extremely concerning. And going back to the population health topic, do we really know and do we trust this patient, all these patients have access to secure and safe and quality cancer care? And that is where Sloan Kettering got the matter in their hands and tried to build a platform that would be helpful for patients to access their care, to access quality care and world-class care. And I was driving those efforts to build a platform that is accessible, feasible, and also cost efficient for patients to drive the initial conversations. And then if needed, they needed to be also in person afterwards.
So we've got a couple of interesting perspectives on population health. One is the tools.
Yes.
So what are the technologies, the innovations, the capabilities, lifestyle management for helping population health? But the second dimension, and so this is a kind of a part A, part B discussion. The second dimension is from a patient point of view.
Absolutely.
What can we do individually? And here's my context. And you might have heard me before. I grew up in a world where healthcare was all about fix me when I broke. Now,
yes.
Today we live in a world where the message is increasingly take care of yourself.
Absolutely.
Then we're there when you need us. So
absolutely.
The shift has gone from me demanding help to now me being accountable for my own wellness and well-being with certain characteristics. And so that said, the world of population health has got a technology capability and a cultural, personal accountability associated with it. I'm curious from your experience and point of view, how are we helping on the tool side? But more importantly, do we need to intervene on the personal accountability and cultural side as well?
Absolutely. And I will take your statement as a golden standard. We do need to take accountability for our health and for our well-being. And the way I connect personal health to the population health is it's a great example of seeing a change in a micro level, how immediately and directly it changes the outcomes on a population level. Particularly in this case, if you're empowering our communities, we are making our community members healthy, obviously our population health outcomes are going to be improved and meeting the goals that we want as a larger population. Particularly, I want to mention under this question about lifestyle medicine and their practice of prescriptive practice of guiding our community members and individuals to use tools and innovation. It fosters basically the opportunity that individually you should take ownership, because now we have the tools, we have so many tools as a matter of fact, that we can choose from, and adapting our daily life to not only proactively prevent what could cause harm and what could cause damage to our health, but also manage the medical condition that we have and achieve the outcomes that we have. And it is we should look at it as it's a supportive, not only supportive system for our own managed care management, but it's a supportive system for the physicians. As one of our panelists earlier mentioned, physicians have very narrow clinical training and focus because that's their bread and butter, that's what they're trained for, myself being one of them at the time. But what we can help our physicians, how we can help our physicians is bringing that the rest of the management of the care, because we're not only working in clinics, we come outside, we go outside, we live in our lives, with our personal life. So we need to have that management across the care continuum.
Well, anything that we can do to help everyone understand that, I think the better, because in essence, if I don't get up and walk every day, it's my fault that my cardiovascular condition deteriorates. If I have 3 too many cocktails and my liver complains, it's my lack of discipline, and one is enough.
Yes, absolutely.
But we've lived in a world where for decades we've effectively been trained that healthcare is our backstop, as opposed to healthcare is our accountability, and that's where I come from. We make a lot of investments, not investments. We help a number of people make investments in technologies, but I think we're too often give short shrift to the personal accountability and the cultural context of that, whether it's US based, whether it's based in Southeast Asia, whether it's based in Europe or Africa. There are cultures there that have got to be encouraged to be adaptive and embracing these capabilities as well. And so I think it's an important dimension that we have to keep mindful of. I'm curious if there's one lesson that you would like to share with our audience today that you've gotten over the last 10 or 15 years. What would it be?
I think it would go back to one of the points that we just spoke, that take control of your health. And there was time that we didn't have the tools. I think the times have changed, specifically after COVID. Be proactive. And one thing that I would definitely highly encourage everyone is there are evidence-based tools out there. Particularly, I do want to mention a couple of spaces in self-healthcare management that you can seek and find tools that are evidence-based. They are not just tools that have been created out of just an interest, but truly evidence-based. Particularly, I would encourage everyone to use self-monitoring or goal setting, social support groups that help manage your health, not alone, but in an evidence-based, proven way. So I would definitely encourage that and emphasize that.
Well, thank you very much. This has been a fun conversation, and I love it when I find a kindred spirit.
Thank you. Thank you, John. You're as welcome. Well. Thank you.
Take care. And we're going to wrap up this hour of John and Friends with a conversation with Buzz Stewart, who's the CEO of Medcurio. Buzz, hopefully you're on the line.
Oh, can you
There you are.
Okay.
Good to see you again.
Yeah.
So we've had a lot of conversations over the last hour and a half about the innovations in healthcare, but it's tend to be focused on what I'd call the clinical character of healthcare as experienced by the individual, whether it be the difference between men and women, the difference in which the tools intervene in our lives, the way the tools turn into population health outcomes, et cetera. Now, you're at a much different place in healthcare, and I think one that is so fundamentally important, which is how does healthcare systematically work? I mean, it's one thing to have a gee whiz device on my hand. It's another to have somebody look at it and says, hey, you've got heart disease. But more importantly, when the therapy associated with my diagnosis time to be delivered, the system grinds to a halt. And so you're at the forefront of trying to actually throw some lubricant into the gears and take some gears out. And so I'm curious, number one, how you guys are doing it. And let's start with EHR data, because in the end, in the absence of somebody knowing something about John, when they touch me and poke me, they're kind of operating blind. So what are you guys focused on? And importantly, how does EHR play into that?
Well, so we believe from 16 years of experience living in healthcare, trying to make more effective use of the data, that there have always been two longstanding pressures that healthcare have faced. It's not new to business in general, but those pressures are really starting to create a squeeze. So one is the unending pressure from the decline in reimbursements. So how much money you get for the same service has been dropping for 40, 50 years. And then the other is the way in which the cost of labor and other costs continue to increase faster than inflation. And so that squeeze doesn't leave many options for any business sector. And the usual solution is you have to figure out how to do more with less. You always come to automation, because that's the way in which you do it. And by automation, I don't mean replacing doctors and things of that sort. There are many things that we can do to make things better, faster, and less expensive, all at the same time. And the challenge with automation always is, no matter where it is, you need real-time data to drive it, especially in the service business, because so much of the service business is about communicating, knowing things about the customer and things of that sort. So real-time electronic health record data are essential, really, and being able to move that and facile ways is essential to scaling automation. And it's true whether you're talking about revenue cycle management, supply chain, the front line of care, patient support services, they all would benefit from having an effective way of triggering AI processes to get work done and things of that sort. And the unique thing about electronic health record data is that it intersects with all of these other data domains that are related to different kinds of services, whether it's on the HR side, the back office, or the front office. And so it is the essential ingredient or fuel that sometimes is combined with other data sources to make things work. And so we believe it's critical to figure out how to drive it.
So it's kind of, it's the main pole in the tent.
Yes, exactly. Yes, very good analogy. Yeah.
So that's, you've made a good case for, there being a foundation or a main pole, but I'm curious now, what do we misunderstand about interoperability? Because it's one thing to have a foundation and a connectedness, but the connectedness doesn't automatically infer interoperability. And so essentially there's the core, there's the connections, and then there's the way in which the pieces interoperate. So I'm curious about how that affects optimizing workflows and real-time access.
Yeah, so that makes me think of Groundhog Day. Because of how many times I've seen the same scenario play out among the same group, and different groups all experience the same thing. And I think the common view, and I think it's increasingly so even with AI and certainly with automation, is that you spend so much time inventing and developing your solution that you think that the work is done once you've perfected it. And then when you actually have to cross the threshold and figure out how to get it operating in practice, that's where you hit a wall, and that's where you realize your work is only half done. And the hardest part of the work is to come, because it's a part of work that you actually can't control. And so the challenge that everybody faces is they have an application that might be really sophisticated, and now they have to figure out how to get data from the electronic health record in real time to their application to drive the processes that make it do its special magic. And the problem is we all are equipped with the same, what I call workaround tools. Others call them interoperability tools, but I call them workaround tools because they weren't designed for automation. They were things we pulled off the shelf when automation came to the front and just said, well, hey, here's some things that you can use. And the experience is common across the board. They just don't work that well. There are data fields that you can't get to. Sometimes the data doesn't arrive on time, or it just doesn't arrive. So there's all kinds of mishaps and challenges in trying to use those that make it very, very difficult to keep your application running well in production. And so you're left to beef up the team that's trying to manage keeping that thing running in production so that your customers continue to trust what it is that you're offering them.
Yep. So I'm going to ask you for some examples in a moment, but let me provide a little context, because this discussion of interoperability and EHR at the kind of the heart of it, it kind of triggered this story, which I shared a little bit earlier, but I'll repeat it quickly, which is a family member, who got what I'd call the traditional answer. Yeah, you need some tests, schedule them. They're 3 to 6, 8 weeks out. And so as an alternative, they went to Mayo. I had heard the name before, but they went to Mayo. And at Mayo, they got to talk to a doctor for an hour. The doctors prescribed some tests, which are done within 24 hours. They were actually able to see the results of the test within minutes after the tests were completed. And within 4 hours, the doctor then intervened and said, here's the significance based on what I've seen. Now, that's wow, right?
Yes.
But that's Mayo. So, so what I'm looking at is, number one, Mayo is highly integrated, and I've known them since I lived in Minneapolis too long ago to remember, and respected the fact that they are a highly integrated, systematic organization, number one. So number one, they're integrated. Number two, they got some really smart IT folks. So for the non-Mayo part of healthcare, what are some examples of the kinds of automation and integration that Mayo is able to do? And I think that, you guys are potentially able to help move along.
Yeah, gosh, there's so many of them, because when I think of where automation is important, I go to where the healthcare dollar is spent, right? And so it's the front line of care where certainly there's amazing things that we could do to liberate doctor time to spend that hour with the patient, talking to them, while documentation gets done automatically, orders are teed up automatically, that whole process. All of that today is theoretically possible, but practically not, because it's difficult to move the data. I think of patient support services and the ways in which we could scale those on like a Salesforce CRM platform and do things that would seem unbelievable today in terms of delivering precisely to the patient's need in a way that they can afford and that enhances their experience. And then I would say the same thing for the back office, RCM, revenue cycle management, supply chain, and things of that sort. But I'm just going to build on your example and just take a referral management process, right? So how does referral management work? It's actually one of the more complicated areas of scheduling an appointment for a patient, because the physician, your primary care physician, might, let's say, refer you to a urologist for enlarged prostate, and he or she doesn't really know that much about your insurance or coverage of that stuff. And so what you'd like to happen is that order gets submitted, and then it automatically triggers a protocol where on a Salesforce CRM example, for example, an AI engine gets the notification, it goes into the patient record, it gets all their information on their insurance coverage, where they live, on the priorities that they have in terms of what labs need to be done before they see that doctor, so the sequencing is done correctly, and all that information, and then can automatically identify referral candidates, prioritize them by what fits, and then trigger an agent, a human agent, to reach out to the patient. But now they've done the 10 to 15 minutes of upfront work and have summarized it in a way that that agent can deliver precise referral guidance and care for that patient, so that the patient gets the labs done before they have the visit, gets to a referral physician that their insurance covers, all those kinds of things that happen, where when the mistakes happen, they all fall to the patient basically and having to pay the price. So there are endless examples of that kind of process, I think, where more precise, more satisfying and effective care can be delivered at a much, much lower cost.
This kind of triggers another kind of word picture for me, which is the tribal behavior of vendor-controlled solutions that exist in healthcare. When I say tribal behavior, everybody defends their tribal territory and are largely unwilling to either build bridges or to create, passageways between them, which might have been for the collective good, but it might have, kind of rebalanced the relationship a little bit. So I'm curious about this historical friction of tribal or vendor-controlled access, and to what degree is that hindering the picture that you were just representing?
Yeah, it reminds me of a term that somebody used the other day, who I was talking to, who knows a lot about this space, and he calls it the walled garden phenomenon. Yeah. And of course, we know about that in our generation. We know about that from the early days of the internet and how long that lasted. And walled gardens are a way of keeping the competition out. But at the end of the day, the walled gardens usually can't be sustained because the market figures out how to solve the problem. And then it's really the market that's more inventive than any single EHR vendor or anybody can be. And I think that's what we need to get to, because those tools that we have, HL7, FHIR, vendor APIs, even custom coded APIs, just can't get us to where we need to get to. We need to have really straightforward, low cost, secure, fast ways of moving data in real time, so that our focus isn't around trying to get the data. Our focus is around the patient, their needs, and how we build solutions that address those needs, is around the overburdened physician and nurses that have to deliver those cares, offloading that work so that they can get back to being what they want to be, and that is great doctors and nurses. And it is all about breaking down the walled garden and structuring things in a way where health systems actually have access and control of their own data to do with it what they want, and not require the permission of the vendor to allow them to use their data.
Yeah. So I'm going to give you a word picture that just occurred to me as we're having this conversation. You guys at Medcurio represents a drone which can rise above the walled gardens, look across all of them, and kind of quickly identify what you need to know from all of those independent areas and assemble it, as a useful picture to the people who you're trying to serve. And so, well done, drone master. But as a closing question, why we've lived with this for decades. I mean, we've both been around long enough to have bruises and scar tissue that are very old and crusty. Why do you think health system leadership still accepts this as a status quo? This what it called walled garden or tribal behavior, because at the end of the day, it's the collective value of all of those pieces that really help improve healthcare, and yet healthcare leadership seems to be content to leave it the way it is.
It's a really good question. Yeah, we are locked in a framework today still, although I think it's beginning to break down because executives and health systems feel the urgency to really transform their business and bring automation into it. And I think eventually that's going to dominate their thinking versus it being dominated by what they're being told by their vendors, that these are the methods that you can use or you have to use, which they don't actually. I mean, that's those kinds of constraints can't be imposed on those who have stewardship over the data and that own access. But I think that I often see health systems in sort of two very different kinds of situations. One is they're early in their journey around automation, which means they haven't done much. And so they don't really know that they have limited access because they haven't really tried. And they don't really understand what they're going through when they're attempting to move beyond retrospective data analysis and starting to use things in real time. So they're not going to get there unless they're pushed really quickly, which I think they will be, to start doing more with their data. And then they're going to hit a wall in a way where they're going to wonder, what is this? Why can't I get my own data? But the more advanced systems have lots of experience with this. And they've developed workarounds around the workaround. So they have layers of work that dominate. And it's almost as though that becomes their status quo. The hard way of doing things becomes their status quo. And it's very hard for them to break out of that, even though if it goes up to the CFO or the CEO, it's costing them a fortune because of what they aren't doing with their data. But I don't think that message is getting across. Often it's defaulted to the CIO making the decision, but the CIO has a very narrow focus and scope where they believe that the way to do things with the existing tools is the safest way, which it turns out not to be true necessarily.
So, well, we all have grown up learning to protect our backside. So
yes,
or protect our six, so to speak.
Yes, it's natural.
Buzz, it's been great talking to you, and look forward to continuing this chat again in another venue. Take care.
Thanks so much for having me.
You're welcome. Bye.
Bye-bye.
I'm going to turn the virtual podium over to our very own Jerry Antomato, who is going to take us home. Jerry.
Thanks, John. Really great segment there to take us into the final furlong of our symposium for March 2025. A really amazing segment of, I think, a newly coined phrase of John and friends, who I think we have to get back on again for the next symposium in April for sure. But some amazing conversations there with John and some of the leading investors and leaders and founders, of course, within the industry right now, that really encapsulate the whole idea of from concept to application in terms of the technology that we are looking at today, and that HITLAB has also worked with over the past. And none more so than the three speakers that we have coming on in the next half an hour to round off the event for today. I'm thrilled to invite three founders who have come through some of the HITLAB competitions that you may have seen over the last couple of years or months even. And first up, I'm thrilled to welcome onto the program today Lars Greeten from FibriCheck, who took part in one of our most recent Breakthrough Alliance challenges. Lars, are you there?
Yes, hi there. Hi, Jerry. Good
Hi,
to see you.
Lars. Good to see you. Good to speak with you today. And we'd love to hear more about FibraCheck and the technology that you have there that's looking and focused on the diagnostics around cardiology. So if you would like if you'd like to tell us a little bit more about yourself and the technology around the PPG technology, in fact, and how it's currently sort of comparing to the more traditional methods around monitoring heart health right now.
Sure. So hi everyone, my name is Lars. I'm one of the co-founders and CEO of FibraCheck. We're a Belgian company that's located in Europe. We've managed more than 1 million people there, and we just got FDA clearance entering the US market. What we have built is a software-based technology platform where we create medical devices at the tip of the finger, basically. And we combine software with AI to convert ordinary devices like smartphones, which is in the pocket of everyone, and also wearables, and actually extract optical data from those devices, PPG or photoplethysmography. And we apply that in cardiovascular domain, where we have a first application now released where we do cardiac arrhythmia monitoring. So we detect irregular heart rhythms. The most known one there is atrial fibrillation. It's caused strokes. It's resulting in heart failure. Morbidities and mortality significantly increases if you have this. But on the other side, it's not limited to that. It's also able to detect non-atrial fibrillation arrhythmias. And that actually distinguishes from a PPG-based technology compared to others in the market. If you look at how does conventional care work, well, typically that is based on electrical signals, so the ECG from the heart. For that, you need a specific device. That can be a handheld device, that can be a patch that you put on, that's something implantable device that they put under the skin. And basically what we say is we do similar things, but without the need of hardware, just a device that you have in your pocket. And we do that with clinical accuracy that is on par with existing ECG diagnostics.
No, that's fantastic. And yeah, if you are more curious about the way that that the technology works, Lars did a terrific presentation at one of the, like I said, competitions that we held, and that's available on our YouTube channel. And congratulations, of course, Lars, on the recent FDA clearance. It's fantastic news, and certainly helps in your continued development. But I'm sure there were some very key challenges that you guys faced, developing this medically certified tool. And we'd love to hear a bit more about how you overcame those challenges in your development.
Sure. The experience that we had from a software as a medical device perspective, I would say there are 3 barriers that we had to solve. One is access, make sure that you're getting on the market. Secondly is make sure that your technology gets accepted by the clinicians and the physicians. And thirdly, it's the adoption. How do you ensure that it's been adopted by clinicians and patients on the other side? Market access, there is a regulatory watchdog there. That's FDA in the US, that's CE clearance in Europe. That is a lengthy process to go through. There is no shortcuts. There's no way of jinxing it. It's really burdening through the process. Key challenges that we had there is how do you make sure that a device that's in your pocket is actually capable of getting this highly clinical grade signal in an uncontrolled condition, whilst patient variability is extremely high and device variability is extremely high as well. And that's where we had to do a lot of AI, a lot of validation work, a lot of clinical testing, but also real world data collection to really prove that that's on par. The acceptance part, that's more a lengthy process. It doesn't mean that if you're approved that physicians therefore trust you. And that's a process where you need to do a lot of publications. We now have more than 90 peer-reviewed publications on our technology out there. That's really supporting us in the backing. We got some guideline recommendations in Europe for this type of technology. US, we're really building on that forward. And then thirdly is adoption. That's making sure that there's reimbursement, because clinicians have an economic model that needs to work around that. But 2, that your patients are also actually using it. And that means that you need to deliver the value, but also the usability to drive such a product. And since we're talking about elderly, this is not like the young, healthy, wealthy that is very sportive, but it's like grandpa, grandma who uses the phone to get WhatsApp messages from their grandchildren. That's the audience that we work with.
So yeah, I mean, I think some real barriers that you guys had to face. You mentioned around about some of the the AI algorithms and things that you guys had to implement. We'd love to hear a bit more about those algorithms that you implemented to improve the accuracy and efficiency of FibriCheck, especially when detecting some of those conditions that you're focused on around AF. And we'd be glad to hear about some of the results you've seen so far.
Yeah, the AI models that we've created are very advanced for the type of technology we're using. So the phone is considered like a dumb data collection device. There's no magic trick that's happening. It's just getting the data it gets. The AI needs to determine, is this data set I receive sufficiently clinically great? And that has different layers that it needs to pass through, different checkpoints that passes through. One is data signal quality. How do we actually differentiate bad quality data from real clinical events? So that is one layer of the algorithm that's really focused and really trained to make sure that's possible. Secondly is how you actually get the right information out of there, that not only the algorithm can see things, but also the human can actually verify what the algorithm is seeing. So that makes it interpretable. So the AI needs to be interpretable. That's a second layer that's very critical, because if we give an output, the physician actually can assess the output, and that's crucial in clinical decision making. And thirdly is, how does the algorithm actually decide what is present, and how does it actually highlight what is present? And those are the three layers there. To build that model, when we started out 8 years ago with this, we were scrappy, dirty performance, but now we built this up with training the algorithms based on our real world data. So the latest model has been trained on more than 1 million data sets from more than 100,000 users. And that means that there's a very high a spectrum of different patient profiles, ranging from skin tone, from obesity, from cardiovascular disease burden. That's all represented in that large population. And then you actually start validating this in clinical studies, and then you see that the performance is really state of the art and industry leading in what we're doing.
No, that's really fantastic. I think those are some really great results to have seen, and some major milestones that you mentioned. I'd like to sort of guide the direction now to sort of hear from you some of the feedback that you guys have got from the healthcare professionals that have been using FibriCheck. That's super important, of course, because one of the things that FibriCheck does is to really help with these sort of existing workflows, especially for the physicians that are giving and analyzing these kinds of diagnoses. So, what kind of feedback have you heard from those healthcare professionals that have been using the solution, and talk about the usability and effectiveness of it?
So the initial response when you introduce such a device to a clinician is that they are surprised that a phone is capable of doing this. So there's a lot of disbelief. So there's first a trust building process in there. Then you see like they start dipping their toes in the water. How does it actually work? They pilot it out, they try it out. Then they start to see, this is actually quite scalable and actually works very efficient, because there's no device logistics involved anymore. I can now manage more patients for the same amount of effort. And then they start to see the data that it generates over time, providing them with new insights they did not have before. And then they understand, this really has a benefit on my pathway. And then you start to understand that there's not one pathway they use, but they're like 20 different clinical pathways. And then you start to see how they start adopting that, how they actually bring that to scale. The largest clinics we have manage between 1,500 and 2,000 patients per year on the platform. So that's really high volume, high throughput. But then you see that it also starts to drive clinical decisions. And then they start to track the metrics, how it actually benefits their practice. And then you see your cost saving, your time saving, your reduction in healthcare utilization. They can triage their resources more efficiently. And that actually drives then reimbursement discussions in the European continent, where we actually got reimbursements for the solution that we have. And US, there's already reimbursement in place. So there's like a value add that we really capture by starting small, building it up. And once it's the economics of scale that really benefit this program, that's where we strive towards.
No, that's really amazing, and I think really benefiting both the patients and the physicians. To really improve the way that this diagnosis is being done right now. Lars, thanks so much for coming on. It's such a pleasure.
You're welcome.
It's amazing to see how far you guys have grown in the last year or so, especially since you guys participated in the Breakthrough Challenge. Congratulations on your recent FDA clearance. That's really fantastic news, and we look forward to hearing more great news about FibriCheck and hopefully having you back on the program. And if you are going to be there in May for the summit, it'd be great to see you in person. And I welcome you to also stay on after you hop off video here. I think there's some questions for you in the chat if you'd like to answer them as well via text. But
I'll do.
Well, it's a pleasure. Thanks so much for coming on.
Thanks for the opportunity, Jerry. Bye-bye.
Wonderful. Wonderful to have one of our finalists of our Breakthrough Challenge come on that's really focused on that keen area of cardiology diagnosis. Moving to our next founder coming on, Sivan Devani of BioTrillion, with a similar sort of focus, but in a more sort of a general way, but very much focused on what's in your pocket and providing a tool that you can use direct from your phone. Sivan, are you there?
Yeah. Hi, Jerry. Good to be here.
Sivan, great to have you on the program. It's a pleasure to have you on. We'd love to hear a little bit more about yourself, being again one of the finalists from one of our recent Breakthrough Alliance challenges, and how BioTrillion's Health AI platform, measuring biomarkers, is transforming the way that self-diagnosis is evolving.
Yeah, so at our core, I paint this vision of what we call a digital doctor in your pocket. Most people I talk to believe that sometime in the near future or far future, everyone in the world will have a digital doctor in their pocket, serving as their 24/7 health co-pilot. Basically, you're in the way the average person goes about the health continuum. We get once a year centralized physical medical setting checkups, and then we're in the dark for 364 days a year. Something needs to take that gap, and that's what we're building. And I can get into much more details about that.
Yeah, we'd definitely love to hear more about sort of what this sort of means in terms of scaling healthcare across, especially globally, with something that's that can be used pretty much anywhere in the world, especially when we look at the way that diagnosis is done in the more sort of underserved and rural populations of the world as well.
Yeah, absolutely. So it all starts for us with the smartphone. We believe that going forward, there'll be these one-off gadgets that measure single biomarkers, and if you're post-diagnosed, that makes sense. If you're on the pre-diagnosed side of the continuum, I don't believe anyone's going to carry around 5 different gadgets, charge it, wear it. But we have seen the duration of the smartphone being the singular device that 5 billion people have and treat almost like their new limb. So that is our focus first. We start with what can 5 billion people measure right now? And then we look into anatomic areas. So we're primarily optical focused in modality. And we use a smartphone camera to measure multiple biomarkers clinically known in the face. For example, heart rate. We can now measure that from the face. There are other indicators, though, of your health from your face. There's pupil dilation, there's eye edema, there's even hand tremor. You're holding your phone. We already look at our phone 100 times a day. Compare that to the 1 time per year we're in a medical setting. It's just like magnitudes different. And so what you need, what healthcare effectively is a method of first measuring and then inferring. And that leads to detection or prediction. But that's basically it. It's measuring, inferring. We don't need to drive 50, 20, 30, sometimes 100 miles to a centralized place once a year for that to occur. I believe we can do that on our phone. So we have 10 biomarkers that span across the face into the neurocardio physiologic pathways. And then from that, this is getting more into the future part of what we're going to do, is we use that combinatorically, like a doctor does, right? They take all these inputs into their head and they think through it like a clinical decision support system, a most likely path that is inferring something about your health, whether it's currently or likely in the future. And that's the other branch of our platform.
No, that's fantastic. And we'd definitely like to hear more about sort of the future of where you're going with BioTrillion. But you mentioned about sort of an everyday sort of, diagnosis or sort of self-diagnosis application for the platform, which can be done without having to visit a centralized sort of location, and that's obviously really, really super useful for the consumers and the patients who will use BioTrillion. But how does BioTrillion and sort of the healthy selfie application of it address more of the B2B vertical, sort of like looking at sort of how it serves the pharma and the telehealth and the payer sort of audiences as well?
Yeah, absolutely. So just to make one clarification, we're not intending to diagnose. We're intending to early detect and monitor risks. So currently, we think of healthcare as really binary. If you're either in the dark, can use a personal example, no cancer, no cancer, no cancer, stage 4 cancer. Right? This is not the way healthcare should be or will be. And so if we could bring those two things in a decentralized way to everyone's hand, measure and infer, we start to empower people with abilities that would only be exclusive to a centralized clinical environment. So this centralized clinical environment that I'm talking about spans multiple sectors. Since you asked, the first part of our business is indeed B2B, and that is measure, give it to a clinician, and a clinician will do what they ordinarily do when if someone is in their physical presence. So largely vital signs. Right? The first thing a clinician does, whether you're going in for a clinical trial with pharma, a medical checkup with your provider, or even a medical exam with a life insurer, the first thing they do is they measure your vitals. Right now, they can't do that remotely. So let's just take telehealth. Telehealth today is no different than a phone call in 1962. Mm-hmm. It's largely verbal. It's one way. It's symptomatic, not signs, and it's coming from patient to physician. Physician has no ability to measure the patient's vitals in a way that they can clinically make important impact their decision making. So we call that telehealth 2.0, when we now add the ability to say, hey, you're having a teledoc appointment on your phone. There's a button that says, click your healthy selfie. Doctor's going to be on the line in a minute. We take a 10-second healthy selfie and we measure 10 vitals and biomarkers within a minute that now can be presented to the doctor and presented in a way that's very informative, but also in the background measures other things that a doctor will never spend the time measuring. So as an example, hand tremor, right? Well, we don't measure that anyway, right? But it's very indicative of lots of different conditions up to diseases. But we can measure hand tremor both in magnitude, but then also in frequency. And that's the type of sub biomarker data that we believe can complement what do you get, 10 minutes in a doctor's office these days? And so more or less the same is occurring in clinical trials where, they will pick endpoints really based on what is specific to the indication that they're talking about. So if it's, let's just say it's Alzheimer's, they'll literally, they need to recruit, and they start the recruiting largely when everyone is herded into a centralized place, and then they have their primary endpoints, and a lot of those endpoints can be digitally measured now, and we can also stratify before they bring anyone in. So as an example, and this is a real one, we have a commercial partnership in pharma. I can use this as example as Parkinson's. They need to get 1,000 people that have Parkinson's. Largely, it's hard to differentiate oftentimes between the two types of dementias, Alzheimer's and Parkinson's. So people come in, then they get stratified, and that's very lengthy in time and costly in money. If we could measure something like hand tremor, plus a couple other biomarkers that are more specific to Parkinson's versus Alzheimer's, you can immediately screen 50% of that group and then have them come in for a more clinically confirmatory stratification and recruitment process. So that's pharma, and then I'll just give you the one more, which is payers, which is, I think, the biggest market, and is where, we started in pharma, but we're going to go next to payers. If we just take the concept of life insurance, the first thing, if you have a very high value policy, the first thing a life insurer will do is say, you need a medical exam. And the first thing you do when you get a medical exam is they measure your vitals. And oftentimes the payer will pay the $500 for that visit if it's a very high value policy. But for 95% of the market who are getting, lower value policies, 500 or 250K and below, they don't want to pay for that medical exam. It eats into their margin. So how do they assess risk? They have people just go online and fill out a questionnaire. There are two issues with that. There's nothing physiologic necessarily being measured there. It's some things like credit score, age, gender. It's not 10 windows into your body. And so imagine if they could now get 2 or 3% more precise in their estimates on longevity based on clinically known markers that provide windows into the body. That is pure margin for the insurance industry. So those are the three markets that.
Yeah, no, that's really excellent, Stefan. Yeah, I think early detection. And I misspoke earlier in terms of diagnosis. I think that sort of early detection and multiple ways of detection, I think, is super important to all of those different verticals and stuff. But Stefan, thanks so much for coming on. Sorry we don't have more time to spend with you. It's really fascinating stuff what you're doing with BioTrillion, and I'd encourage the audience today to connect with you on LinkedIn and find out more about the great work that you're doing.
Great. Thanks for having me.
Thanks so much, Stefan. Okay, and we are into the final lap of our session for today, and it's my honor and my pleasure to welcome on Dr. Mary Catherine George from the Icahn School of Medicine at Mount Sinai, who took part in our most recent Women's Health Tech Challenge, and she's developed a very novel solution, ComfortWave VR, and we've gone from remote patient monitoring, detection and diagnosis to more managing chronic pain and care. MC, great to have you on the program. Wonderful to have you back on. We'd love to hear more about what you're doing with ComfortWave VR, and specifically how you sort of identified PMPS as sort of one of the key areas where the technology could make a real impact.
One of the problems with chronic pain is that the medications that we have available are not really sufficient. And there's such a subjectivity to chronic pain in patients, no matter what type of pain they're suffering from. So, many of the modalities that are behavioral are very time intensive. They involve getting with a therapist, and that's where the inspiration came from. We know that self-hypnosis, if you can teach a patient self-hypnosis for their chronic pain, they do much better at managing their pain. We did a study back in 2013 where we used this with HIV chronic pain. And the challenge is how can you get patients to go to a hypnotherapist and do the many sessions to learn to self-hypnotize? And I guess when I saw virtual reality being a big movement in rehab, it was helping people who have pain, back pain, and using a rehab model with virtual reality helped people kind of like stop having that fear avoidance of movement. And I thought, oh my goodness, this would be wonderful if we could see, if we could validate what is self-hypnosis into a virtual experience. So we've spent the past year working with engineers to develop this software and the virtual experience. And, you know, we're just now starting with patients. And I think that, you know, just from our study team using it, we find it amazing right now.
No, that's really, really wonderful. Can you talk a little bit more about sort of that launching, like, you know, that sort of study with an FDA abbreviated device and sort of the steps that sort of go
Well,
into it right now?
you know, I love that we had these two previous presenters that you discussed about their process of bringing something to the market. You do want to know what the FDA is going to perceive of your device and your software. And so for me, I started out trying to get a Q submission, which is kind of a lengthy process. And you put all your questions about what would they agree to approve in a software that would give a person that has chronic pain, such as from post-mastectomy pain syndrome, would give them relief. What would you want to see from a research perspective that would give us the approval? And let me tell you something, that was a major engagement with the FDA, especially when you're talking about, first of all, chronic pain, which is very subjective, and then someone's own experience in a virtual world and how that they perceive it and how it impacts that pain. So we had a very lengthy discussion, but eventually, you know, it is all about biologics. They want to have heart rate variability. They want to have an EEG. They want to have, you know, function measured like steps and walks and then duration of pain relief after the treatment. So we've really move towards those things, but right now the funding is very limited to add some of those biological measures. So, you know, we're chronically looking for funding so that we can meet an FDA requirement to have these biologics that demonstrate not only is it something that a subjective patient says, oh, this is helping me, but it actually shows the biological measures that demonstrate it can help you.
Yeah, it's certainly a long road, and it's a process, and it's not made easy for you for sure.
No, it's not.
But one of the things that we really focus on at HITLAB, of course, as you know, is evidence based research on these different technological solutions in healthcare, and you yourself have had great tenure in the research game, if you like, at Sinai. So just to wrap up, because we are at time, unfortunately,
definitely,
we'd
no
love
problem.
to get your take on the evidence and clinical data that's supporting sort of the effectiveness of what you're doing with Comfort Wave VR in treating PMPS and chronic pain, and how you measure that success in essentially improving quality of life.
You know, patients who have used this both pre and post surgery, there is good data out there for patients who went in to have a mastectomy, used self-hypnosis. I don't know what they actually used in the software, pre and post the surgery, and they benefited greatly. Now, they didn't continue to use it because I think there was a limitation of access to the device. But definitely we have a huge amount of information that if you teach a patient self-hypnosis, they will benefit. And see, I think what I believe is by giving a patient this tool, this VR tool, it's a concrete tool that creates that sort of calming, mindful presence. And for me, I think what is even more impactful is it kind of detaches the person from their perceived pain perception. I think that's where the power is, and it's hard to demonstrate that. But I think that if we put our biological measures on what we're doing, we're going to have that data. So I'm very, very excited.
That certainly sounds exciting. It's a wonderful way to round off our conversation and the symposium for today. MC, thanks so much for coming on and sharing
Thank
your
you.
insights with
This
us.
is always a pleasure.
Exciting to see where you're going to go with Comfort Wave VR.
Me too. Very
Yeah, look forward to having you back on the program again.
definitely.
Okay, so that rounds off our symposium for March 2025, looking at the concepts to applications of the way that digital health solutions are transforming the world of healthcare. We wouldn't be able to bring this program or the subsequent programs and past programs to you without the help of our amazing team that works so hard in the background: Rachel, Ansley, Raymond, Pallavi, Melissa, Sammy, Nico, Rijo, Mr. John Hammett, and Mr. Stan Kishnowski, of course. Amazing work done behind the scenes to bring you programs such as these. And of course, we couldn't do it without our partners and our sponsors in the Merck Global Health Innovation Fund, Helix VM, Fox Rothschild, Versely, IMC, FFF Enterprises, or Silicon Valley Bank, to name but a few. And if you are interested in supporting any of the programs, please reach out to me or Stan, and we'll see you all on the next symposium. Take care, everyone.